A very good evening to one and all. We bring season's greeting from the Public Awareness Committee, FOXY. We invite you to the 19th episode of this awareness series, which we are running throughout the year with respective zones. With this, we are into the 19th episode today with the South Zone societies. We are very thankful to Rishikesh Pai sir and Madhuri madam and Alka Pandey madam for allowing us to conduct this series. This is a brainchild of Dr. Priyanku Roy, who is the chairperson of the Public Awareness Committee. And this time we are focusing on menopause and antenatal screening because October and November are awareness for these topics. Can we have the inauguration slide, please, Abhishek? I request all the esteemed faculties to please join us for the lamp lighting ceremony. Thank you, Abhishek. I would now like to introduce our chairperson, Dr. Priyanku Roy. He is currently the chairperson of Public Awareness Committee and the president of WATOC. He has been the national coordinators for various committees during the COVID time. We welcome you, Priyankur, and I request you to please introduce our guest of honor, Pesi sir, as well as Revati ma'am. Narasimha sir will join a little late. He is busy with our emergency cesarean section. Can we have the slides, Abhishek?
Yes, ma'am.
Thank you so much, Monica. It indeed gives me immense pleasure to welcome everyone to this wonderful webinar, and we're really thankful that everyone has participated in the 19 webinars that we have conducted so far. We have been doing it on a zonal basis, and today we are really thankful for all our esteemed South Zone faculties who are there with us in this program. So before I introduce Madam, I would just like to welcome everyone to this session. And I would like to, of course, thank Rishikesh Paisa, Madhuri Patel ma'am and Alka ma'am for giving us this opportunity. I would like to thank my coordinators, Monica and Shatabdi, without whom this series would not have been possible. And you have seen how much effort they have taken in coordinating with all of you, talking with all of you, and getting this whole session going. I will thank my conveners, of course, Bharti ma'am and Raghavendra sir, who have also done a lot of work towards successful conduction of this webinar series. Our guests today, Dr. Revati Janakiraman ma'am, Dr. Narasimha Reddy sir, and Dr. Fesi Lewis sir. I thank all of you for agreeing to be with us today in spite of your busy schedule, and that means a lot to all of us. The scientific session, of course, cannot be has to be like, we have been focusing mainly on the scientific session to have the best of speakers and our faculties so that everyone benefits from the sessions. I would like to thank our speakers Ambuja madam and Bharti madam for agreeing to speak on MHT in 21st century and WHO updates in ANC. Our chairpersons Rajshri madam, Raghavendra sir, Suchitra madam, as well as Sonia madam for being with us in today's session. Our moderators today again are two dynamic faculties, Dr. Jayarani Kamraj ma'am and Dr. Niharika ma'am, and our expert, Dr. Sheila Mane ma'am. Thank you, ma'am, for joining us. Panelists, we have today with us Dr. Parvati, Dr. Radhika, Dr. Shobha, Dr. Padma, Dr. Shamima, Dr. Anjum, Dr. Suma, and Dr. Shubha Ramarao. So I thank all of you for being with us today for this session. Now, I would like to welcome our guest of honor. First of all, I would like to welcome Dr. Revati Janakiraman madam. She is, of course, a professor, a very loved professor, I must say, in Department of OBGYN at the Madurai Medical College. She has been the former director of IOG Chennai. She has been the vice president of Foxy South Zone 2016. She's currently the president of TNFOG. She has received a number of awards, including the Lifetime Achievement Award by IMA Madurai. She has also received the Pride of Foxy Award in 2019 at Mumbai. Welcome, madam. I would like to request you to say a few words to everyone present over here as a token of your blessings for everyone.
Thank you. Thank you, Dr. Priyankur. Good evening, dear friends. It's my great pleasure and privilege to be here in this 19th episode of Foxy Public Awareness Committee program conducted along with South Zone. All that we learn should ultimately reach the public by way of our services. In that way, The topics chosen today are really very, very important practically. Take, first of all, this MHT, current updates. Unless we have a clear idea on MHT, we cannot guide our women suffering from menopausal symptoms. Here is my friend Dr. Ambuja, an authority in this subject, to talk on this. Also, antenatal care, which is very essential component in reducing the maternal mortality. Dr. Bharati Rajasekhar is going to discuss about WHO updates on antenatal care. She is a candidate for chairperson, Food and Drug Committee FOXY in this forthcoming election, and I wish her all the best. Perimenopausal AUD is really a tricky situation to handle, especially in this era of Save the Uterus. When and how to intervene when you meet such patients. I'm sure Dr. Jairani and Dr. Nigareka, along with the expert Dr. Sheila Mane, will bring out salient points which we have to follow in managing such special area in AUB. Overall, I expect this to be a very informative as well as an interesting session. Thanks to Dr. Priyanku and the entire team for your kind invite. I wish this webinar a grand success. Thank you very much.
Thank you, Revati ma'am. It definitely did mean a lot to us. Thank you so much for coming, ma'am. And thank you for your words of application. Thank you so much, ma'am. Dr. Narasimha Reddy sir will join us in some time. So I would now like to welcome Dr. Fessy Lewis sir. Of course, Fessy Lewis sir, everyone again knows him. He is a professor at the Department of Reproductive Medicine at the Amrita Institute of Medical Sciences. He has been a past vice president of FOXY. He has been a chairperson of the FOXY International Academic Exchange Committee, member of FIGO committees. He has been the secretary of the Kerala chapter of ISAR. He has received a number of awards to his credit. He has been the vice president of KFOG as well. And it's an honor to welcome sir to this platform. And we can see him already smiling, and that's his nature always. And that's the best part that I would say. So welcome, Fessy sir, to please bless all of us for this webinar.
Good evening to all of you. First of all, it is always a pleasure and a proud privilege to be invited to any academic activities, especially by the FOXY and by the vibrant, one of the most vibrant committee chairperson, Priyanka Roy. I think as the previous coordinators was telling, this is the 19th episode. And still it is running successfully, and the importance is that the topics which are selected, as Ravati Madam told, the speakers are experts in the field, and the topic not only relevant in theoretically but also practically how we can use in our helpful in our clinical practice. So I think here we have got menopause, antenatal care, AUB, all by the experts are here. So I think whatever planned and done by Priyanka will be always so practical and useful thing. Wishing this webinar of the Public Awareness Committee all the best, and without wasting time, we will go ahead with the rest of the deliberations. Thank you for inviting me.
Thank you, Fessy sir. It's always a pleasure listening to you and having you in the program. Thank you once again, sir, for being here. Now I hand over the session to Monica to kindly continue with the scientific session, and I'm sure it's going to be a feast to everyone, all the attendees who are present over here. And just to mention at the beginning that sometimes we look at the participants list and we feel a little demotivated thinking there are only 21 people here. But this is only the faculties who have joined this program, and we have already 120 plus people who have joined this program. So there are a lot of people who are waiting to listen, and I hope this program will bring a lot of knowledge sharing to everyone. Thank you so much. Over to you, Monica.
Thank you. Thank you, Fessy sir, and thank you, Revati ma'am, for joining us and blessing us. We now start with our academic session. The speaker for today is none other than Dr. Ambuja ma'am, and our chairpersons are Rajeshri madam and Raghavendra sir. Can we have their CVs, please? Dr. Rajeshri madam is the General Secretary of KASOGA. She is currently the chairperson of Genetics and Fetal Medicine Committee of KASOGA, the president of the Kalaburgi OBGY Society, and the vice president of Rotary Club Kalaburgi. She has been an examiner at UG and PG for Karnataka, Maharashtra, and Telangana universities. We welcome you, ma'am. Our next chairperson is Raghavendra sir. He is currently the South Zone Coordinator for Public Awareness Committee, a Director of Infertility and Fetal-Maternal Unit at Sunrise Hospital, and an Executive Director in ARMC IVF Mangalore. We welcome both of you to please chair the session and introduce our speaker today. Rajeshri ma'am, can you unmute yourself? Hello?
Hello.
Yes, sir, Raghavendra sir, please introduce ma'am in the meantime.
Yeah, good evening, everybody. It gives me immense pleasure to introduce Professor Ambuja. She is the president of Indian Menopausal Society 21-22, research committee chairperson for SAFOMS 21-23, retired professor and HOD Institute of OBGYN, Osmania Medical College, Hyderabad, visiting professors in the University of Chennai from 2019, All India Vice President, Family Planning Association of India, Treasurer for Society of Obstetric Medicine of India, and peer reviewer for Jogi. Also, she's a consultant editor of JK Science, Journal of Medical Education and Research. She is also a UG and PG examiner to various medical universities. And can I have the next slide, please? And
Sir, this is the CV.
okay. And Madam is going to enlighten us on HRT. Over to you, Madam.
Thank you, Raghavendra Prasad. Nice of you to introduce me. Good evening to everybody. Thanks for, hello, are you able to see my slides?
Yes, madam, but not
Yes,
in
Yes, ma'am.
Yeah, am I audible?
Yes, ma'am.
Yes, ma'am.
Yeah,
Ma'am, if
just
you
a
could just
minute.
make it full
Can I
screen if
make
you
it
don't
full
mind.
screen? Yeah.
Yeah,
Perfect.
perfect.
And first of all, let me thank for inviting me to this prestigious committee meeting of obstetrics and gynecology, FIGO. And the special thanks to Vibrating Priyankur Rai. Though I haven't met you personally, but I always I am very fascinating in hearing your presentations and all. And thank you very much, Monica, always involved in calling and a very receptive attitude of yours. Actually, you know, menopause is a less scared branch. Everybody is delighted to talk about either infertility or about the contraceptives, or when the IVF baby comes out, they're all very happy and all, but not about the menopause. Even the patients itself, women itself, they are not very readily accepting to talk about the menopause. All of you know that it is a hormonal deficiency stage that is there. There are short-term and long-term complications. One thing I want to know, when you know the people are suffering with this, how many of us are prescribing the hormones very confidently? I don't think it is being done. Then how can we expect an ordinary person to ask us, they need hormones, they are suffering like this? So I think this is the field which needs lot of awareness, public awareness has to be created in the public. And I say, Priyankur Rai, you have selected the topic very aptly, and it is the need of the hour, because more than half, previously it was only 1/3 of the population of women population, but now it has exceeded more than half of the population are in the menopausal age group. So just I want to know, is there any difference in menopause between 20th and 21st century? Menopause is menopause, stopping the menstruation is the menopause. But still, yes, there is difference. The age of menopause has increased. And second thing is, population also has increased. Menopausal women has increased because the longevity of the person, female, has increased. One thing what we should understand is non-communicable diseases increase with the post-menopausal years, how many years they spend. For example, I'll tell you, if the person's reproductive period is less than 30 years, 40% of the women will suffer with the diabetes or the pre-diabetes. So that's so much of difference is there. So we are always bothered about the long-term complications. Short-term, of course, that are there. So the difference between the 20th and 21st century is, though it has started the hormone therapy in 1940s, and people were enjoying taking estrogen, and estrogen. Actually, there is a book, Femininity Forever, but it doesn't hold good. They developed all the complications, endometrial carcinoma and all. All of you know the WHO study that has come and abruptly stopped with all the little of the bad communications that were there with that one. So what did we learn by WHO? That's what is very important. And how did we improve in 21st century because of this? One bad thing that is there, taking people HRT, they have stopped. There is sudden decrease about 32% by 2003. But what we understood, a follow-up study of 13 years after the WHO is all the hormones, either estrogen or progesterone, the benefits were more than the harms that were there. When the study, it was done in a 5-year course, and this is the one produced in the Journal of Clinical Endocrinology and Metabolism in 2010. Though the results of the WHO study came out in 2002, this is followed, and the results were expressed in relative numbers, not in the absolute numbers. The only 4 things that bothered a person is 8 more women of the breast cancer per 10,000 women that were studied, and cardiovascular accident in 6 cases, stroke and pulmonary embolism. Only these 4 were the contradictory points. But any day, if you say the name of cancer, wherever it is, everybody is so scared. Even me, I won't take, or I won't give. That's what. There is no confidence in prescribing the hormones or by the doctors, and by the patients also we were not taking. So now I am going to discuss only these points, how we have improved in that one. Net results were 30% were taken in 2001. It has come down to 10%. With that, there is a loss because they were suffering with the postmenopausal symptoms. $1.8 billion was lost every annually. So the unmet need for non-hormonal alternatives has come. So the people are waiting to have a non-hormonal or hormonal treatment. What has changed in 21st century is, one, during the WHO study, it was the HRT, what when a common dose given to everybody, that has changed to MHT, that is the menopause hormone therapy. That is the individualization for each patient, each woman. It is done. We cannot call them as patients because the menopause is a physiological process, not pathological, except the premature ovarian insufficiency, and redefining the age of menopause hormone therapy. You should not give menopause hormone therapy after 60 years. If it is given between the 50 and 60 years, yes, benefits outweigh the risks. And usage of natural estrogens, that is estradiol and natural progesterone, other than the synthetic estrogens and progesterones, or primary, that is the conglomeration of so many estrogens that were there. And introduction of the non-oral routes of estrogens and progesterones. Even for the progesterone, vaginal route is available, that is called the GenPro. And risk stratification before starting MHD. These are the changes that happened in the 21st century. With this, the absolute number of complications that are occurring have come to the minimal. We cannot say it is 0, but it has come to the minimal. What is the outcome of it? So what is today's stand in prescribing MHT is, MHT is not for all postmenopausal women. It is only for indicated. What are the indications? The main first one is the vasomotor symptoms, And there the grading is there. All of us know it is the grade A recommendation, because don't allow anybody to suffer with the vasomotor symptoms. And for premature ovarian insufficiency and early menopause, genitourinary syndrome of menopause, they are all the grade A recommendations. And never we used it previously for prevention of any of the diseases. But now it is very clearly in 2017, it has come out, prevention of osteoporosis and fractures in high-risk patients. Recurrent urinary tract infection, after ruling out other causes, we can prescribe the hormones for them. MHT started within 10 years of menopause, below 60 years of age is very safe. But it is not for prevention of primary or secondary non-communicable diseases, that is diabetes and metabolic syndrome or Alzheimer's. And there are, in 2002, some of the things are added. What are they? One is, whenever you start the hormones, you see the risk calculation of the patient is very important. And it is said that transdermal estrogen is the route of choice, better tolerated and better results will be there. These two things we have to take it into consideration. For example, I will tell you, I'll just explain by doing this. A 48 years bank officer with severe vasomotor symptoms, no comorbidities, and personal and family history are uneventful. She read from Google, menopause is estrogen deficiency state. She will get heart attack or breast cancer with hormones. She wants to know what can she take. So how am I to do with that one? This is what is the present, the clinically acceptable thing. What we have to do is don't divide, don't go on divide anything like that. So our role and how to approach is it a symptomatic or asymptomatic? For everybody, you do the risk stratification first. The symptomatic patient you treat, and asymptomatic, it is the preventive health that is very, very important. If you just go like this, it's very easy and patients are also comfortable. So risk assessment is the estimation of the risk of initial disease in an apparently healthy asymptomatic individual based upon the assessment of multiple variables. After the WHO study, what are the things that we have to take into risk? That is, one is the incidence of breast cancer increased and myocardial infarction has increased, and DVT. These three are the things that are there. So we have risk stratification for everything, but only thing is, these are all the things that are there. But here only I'm going to tell only three, because the mortality because of the cardiovascular accidents has enormously increased after the menopause in women compared to men. Before that, it is almost equal, and we can say that it is less. And the accidents, CVD mortality compared to any other cancers or anything, it is more. So it is now our duty to prevent the cardiovascular accident. So history taking is very important. What are the things it is, what we take is the adverse pregnancy outcomes is very important, which says there will be 4-fold increase in the cardiovascular accidents if these things are present in the pregnancy. What are they? Hypertensive disorders, JDM, and preterm birth and pregnancy loss, IUGR. If they are present, ACOG recommends that women with these things, they risk scanning within 3 months postpartum. We have to see, and you should follow the preventive aspects. This is already, that's there in the internet. I'm not going to tell, but simple measurements is enough to calculate the risk. That is the age, blood pressure, and triglycerides. This is very important. When you plot for this, we will know where she stands, whether she is a low risk, moderate risk, or high risk. What is the use of calculating? That's what is very important. When you calculate, if it is a low risk, we can go ahead with the menopause hormone therapy. If it is a moderate risk, go for transdermal MHT, because oral MHT, always this is a damage to the liver and it causes the havoc because it has to pass through the metabolize through the liver. But transdermal, it overcomes the liver. And high risk, you avoid MHT, go for the alternate things. So what the American Heart Association recommends is HRT not for sole purpose of primary or secondary prevention of cardiovascular disease. HRT should not be initiated within 1 year of cardiac event. For other indications, risk from MHT is seen in the first year of pro-inflammatory state. While on HRT, if there is a cardiovascular accident, even cardiovascular event or immobilization, please discontinue the HRT. Oral estrogen therapy is contraindicated in women with deep vein thrombosis, and transdermal is preferred for that one. So this is what is very important to know, how we are going about it. Blindly, we will not give any hormones. These are all the things has to be followed to get a good results. What about the breast cancer? Just now I told you. And the longevity has increased as the women survives for a longer time. The incidence of breast carcinoma increases without giving hormones or with giving hormones. Along with the hormones, a little incidence is more, especially if there is a family history is there. So taking the risk stratification is very, very important. And especially in the cases of high circulating estrogens, means it is the fatty person. If it is present, the fat is converted into estrogen. Those periods, the risk of carcinoma is there. And second thing is, if the patient, the reproductive age is less, means like premature menopause or early menopause, if it is present, they are more prone for the breast carcinoma. But what current guidelines says is, current guidelines typically consider HRT is contraindicated in breast cancer survivors. Why this has come? I showed you in the beginning itself. What are the benefits and risks? Actually, by giving carcinoma, the carcinoma breast has estrogen carcinoma breast has not increased, but still, randomized controlled trials did not prove it completely. That is why until now it is not accepted if the history of breast cancer or if the patient has suffered with the breast cancer. Please don't give the things. For these people, non-hormonal is the first. What are the non-hormonal? That is the venlafaxine or paroxetine, gabapentin, and clonidine. This also can be used. And patient on tamoxifen, antidepressants are less effective. So what about the urological problems and with the breast cancer? Vaginal estrogen can potentially stimulate occult breast cancer cells. You see this. So vaginal laser therapy, it can be used, but the efficacy is not established. And another drug, that is the ospemifene, which can be used orally, this tablet, 60 milligrams once a day. It has been approved, but their safety after breast cancer has not yet been established. When so many ifs and buts are there, it is little difficult to prescribe. Going to the venous thromboembolic complications, yes, definitely, estrogens are contraindicated. Go for the non-hormonal treatment. But if only varicose veins are present, either transdermal or tibolone can be preferred as the route of administration. One recent systemic review and meta-analysis published indicates that HRT does not increase all-cause mortality. This is very important. So you can prescribe very safely if there are no contraindications that are present. After knowing this, where to give HRT and when not to give HRT, now we'll go to the type of hormone that we are going to prescribe. Does the estrogen matter? Yes, definitely it matters. Previously, when the WHO study was done, it was the prebarit, conjugation of so many estrogens from the pregnant mare's urine that is present is not akin to the natural hormone produced in the body. So, estradiol is very close to the natural hormone is produced, and so this is better. And second thing is ethinyl estradiol, what is used in the oral contraceptive pills, definitely it is very bad, and so don't use ethinyl estradiol for the purpose of menopause hormone therapy, because it is 100 times more potent than the 17 beta estradiol. So benefits of 21st century are because of the type of hormones, dose, resin, and route. So what is the dose which we are using? One, definitely 17 beta estradiol, nothing other than that. Either oral, transdermal, spray, or gel. Actually, transdermal is much costlier than oral. That's why in India, we cannot give transdermal to all. We are preferring oral. But wherever oral is contraindicated, please go for the transdermal. It is very good. And now 17 beta estradiol transvaginal route also is available. Progestogens, definitely we are going for the dihydroprogesterone or micronized progesterone. Always micronized progesterone is better than dihydroprogesterone, but because the dihydroprogesterone is in the tablet form, people prefer to take that one. The next one is the tibolone, which is the SERM, that's also is very good. And bezodoxifene complication in combination with the CEE, where progesterone replacement, where progesterones are contraindicated, we can use bezodoxifene. But still, bezodoxifene, ospemifene, they are still in the pipeline and not completely proved, but still we can use. It's not available. Both of them are not available in India. Ospemifene for the vulvovaginal complications and DHEA. These are the things that we can use it. Not going into the details of all these things, I will tell you, estradiol is more lipid friendly. Means the HDL increase and LDL decrease. It is more with the triglycerides, more with the estradiol, and with the transdermal route, which is preferred than the oral route. That's what is the compared to the conjugated equinoestrogen. That is why it is always preferred. During the menopausal period, this is the high density lipoproteins is a anti-inflammatory than the low density lipoproteins. So this is the more we depend more on the high density lipoproteins. And to control the vasomotor symptoms, any estrogen is good. You take it is going to give good result estrogen. But 17 beta estradiol is preferred because of its lipid profile and effect on the heart that is there. And even the bone mineral density, this is any estrogen is good, acting on the vertebrae, femoral neck, and the trochanter. But still, it is the 17 beta estradiol, it is preferred. What about the route of administration? I already told you, wherever it is possible, transdermal is the best. But when it is not possible, when there is no contraindication, we can go for the oral route. And what about the venous thromboembolic complication and administration of hormone therapy? Obesity is definitely at any age when you prescribe, this is more dangerous and it produces the venous thromboembolic complications. It's much more dangerous than smoking or drinking or whatever is the complications there. Obesity is very, very bad. That is why the controlling the weight during menopause is very important. And another thing is the transdermal, just I want to tell because it's recently introduced in the in India. It is the metered dose transdermal technology that is there. And it is only 1.53 milligrams, very minimal dose that will be used. And average drying time is only 90 seconds. And no need to wash the hands or no skin to skin transfer. These are all advantages that are there. We talked about the estrogens. What about the progesterone? Yes, definitely. Synthetic estrogen and progesterones are very bad. They are the culprits in producing the breast cancer or myocardial infarction. With synthetic progesterones, there is increased risk of cardiovascular disease and venous thromboembolic complications that is not there with the micronized progesterone. What makes dydrogesterone a unique molecule? We should know, because in India, we are not using not much of the micronized progesterone. Dydrogesterone only we are using. Dydrogesterone is highly selective for progesterone receptors, thereby decreasing the risk of adverse effects. It has got no estrogenic, no androgenic, and no glucocorticoid effect. This is what is the thing that shows that dydrogesterone is also a better choice we can use in the when hormone replacement, when menopause hormone therapy. What about the choice of progesterone and breast cancer risk that is there? We already said we have to calculate the breast cancer risk before prescribing the drug. You see here, without using this is the placebo, when the risk, I told you, as the age itself produces the increased breast carcinoma, with the dydrogesterone, it is a very minimal, we can easily prescribe. That is why we are thinking that either micronized progesterone or dydrogesterone appear to be low risk association of the breast cancer. Finally, he's the Toby of Willers. He's the chief investigator of this WHI. Finally, what he told, after 15 years of WHI, the big concern in clinical practice is not the overuse of hormones, but we are denying the opportunity of the people who need it. And we are increasing the all mortality or the complications or for the communicable diseases more, because we are not using the window of opportunity for otherwise people who require the hormone therapy. So we have to use whenever it is necessary. Coming to the types of hormones that are available for us is only the oral routes. The combination of 17-beta estradiol and dydrogesterone are available for us. The dose perimenopausal 1 milligram of estradiol plus 10 milligrams of dydrogesterone in sequential type of regime means every day we are using for 28 days and then stopping. They are going to get the menstruation. That's what is, I'm sorry. Sequential is first 14 days we use only estrogen, second 14 days, both estrogens and progesterones we use, so that at the end of it, they get the withdrawal bleeding. And postmenopausal, continuous will use so that they will not get any withdrawal bleeding. Why we are using 10 milligrams of dydrogesterone in sequential is very important, because unless the sufficient dose of the progesterone is present, the endometrial protection will not be present. So with the 5 milligrams for 5 days or 7 days, it's not going to give any protection to the against endometrial carcinoma. There are cases presented with endometrial carcinoma if lower doses are given less than 10 or 12 milligrams. That is why sequential regime, minimum 12 to 14 days, we have to give 10 milligrams. But in the combined regime, where we are giving 5 milligrams daily, that leads to the atrophic endometrium. I hope I made it clear. What about the genitourinary syndrome of the menopause? Yes, low dose of vaginal estrogen, good. Vaginal DHEA is also good. Ospemifene, just now I told you, it is under pipeline. It is also very good. And systemic ET helps, but not to the fullest extent. With all these things, is there any alternatives in adding to the progesterone? Yes, tibolone is very good because it is the estrogenic, progesterogenic, and androgenic, and selective estrogen receptor modulator that is also there about the levonorgestrel containing IUCD. And what are the latest things in the pipeline? It's only just 2 slides are there. This first-in-class neurokinin 3 receptor antagonist is an alternative to HRT for women with a history of breast cancer, blood clots, and those who prefer non-hormonal treatment. This is the latest one that's coming. Still not available for us, but we should know what it is. The Bayer has another neurokinin antagonist in phase 3 trial. And following this, we will get it as the Candy Therapeutics. Other innovative approaches in phase 2 trial include DARE Biosciences intravaginal ring that delivers estradiol and progesterone over 28 days, eliminating the need for a daily intervention, and Vistagen's rapid onset nasal spray to treat vasomotor symptoms and migraines is also available. For the osteoporosis, 2 first-in-class injectable biologics are available. One is Prolia and another is romosozumab. These 2 things are coming. They are to be very good. So to conclude, way forward is the time has arrived to shell the WHI and its limited applicability to the lives of menopausal women. Human identical transdermal estradiol and micronized progesterone are proved to be very good. And there are different effects seen with natural and synthetic progesterones. Heart pressures are surrogate markers for future cardiovascular disease. Non-hormone medicines for heart pressures, venlafaxine, paroxetine are good. Tibolone is preferred for mood and sexual dysfunction. Vaginal dryness, we can use low-dose hormonal rings, tablets, and E2 capsules. For vulvovaginal atrophy, E2 capsules are as effective as laser. We do not go for the laser therapy for everybody. E2 capsules are available. That's also is very good. Thank you very much for giving the opportunity. Any questions? I'll be ready to answer. Thanks, everybody.
Thank you so much, Ambuja ma'am. That was indeed an elaborate lecture. I would like Raghavendra sir or Rajashri ma'am to kindly give your concluding remarks on ma'am's talk.
Can I have a question?
Yes. Yes, Parthi madam, please go ahead.
Dr. Ambuja madam, it was a very clear and explicit talk about this very often confusing topic of MHD. Madam, I have a question. If you don't have any vasomotor symptoms and hysterectomized women, is there any necessity for estradiol replacement?
Madam, in the first point, I wrote you very clearly, MHD is not for asymptomatic patients.
Okay,
if they have symptoms, only use it, otherwise not.
Otherwise not needed.
Other prophylactic measures like exercise, diet, and so many things are there, like using the calcium. These things are very important than going for the MHD. It is not indicated.
Thank you, madam. Thank you very much.
Namaste, Ambuja ma'am. It's my honor and always a pleasure to listen to you. And we have all the time been benefited and educated by your talks. Very crystal clear and very apt messages for the audience and just what is needed. Even though we have come a long way in the management of menopausal symptoms and menopausal therapy, it always remains a doubt as to what to initiate for which kind of patient. And because every time we have in the back of mind the risk of cancers which go for the patients who take unsupervised medications. Once we put in a medication, the patient understands that this is benefiting them and they continue to take it long. And we have seen problems occurring because of that unsupervised medication. So counseling and the care and the monitoring, the supervision, definitely, we need to overemphasize upon these aspects that every time we initiate a management, it should be made understood to the patient that this has a limitation and it has to be taken for limited period of time. Very nice lecture, madam. Always a pleasure to listen to you. Thank you so much.
Thank you, Rajashri. So nice of you. Bet after a long time.
Yes,
nice
ma'am. Yes,
thank
yes.
you.
I thank the organizers for giving me this opportunity to.
Excellent talk, Dr. Ambuja, as usual.
Thank you, Johnny. Thank you, Revati. So nice to listen.
Nice.
Yeah. I thank the organizers for giving me this opportunity to be here on this occasion. Thank you so much.
Thank you
Ambuja
all.
ma'am. Thank you, Rajeshri ma'am. Thank you, Raghavendra sir.
Thank
We
you.
will now move on to the next
Thank
talk.
you.
Our next talk is by our very own Dr. Bharti Rajashekhar ma'am. Ma'am will be speaking on WHO updates in antenatal care. To chair the session, we have Dr. Sonia Mandappa ma'am and Dr. Suchitra Sudhir ma'am. Can I have the, yeah. Dr. Sonia Mandappa ma'am is a consultant at Motherhood Hospital, Mysore. She is also the advisory. She has been the advisory of the Breast Committee of Kasoga as well as the Safe Motherhood Committee. She is also a member of KCOG and the secretary of AHPI Karnataka chapter 23 to 24. Welcome, Sonia ma'am. Our next person, our next chairperson is Dr. Suchitra Sudhir ma'am. Ma'am is a senior obstetrician and gynecologist at Ashraya Hospital, Matanur. She has been the president of Kannur OBGY Society, vice president of KFOG between 2019 to 2020, as well as the medical director of the breast cancer brigades of Malabar Cancer Care Society. Welcome, Suchitra ma'am. I would like, yeah, welcome ma'am. I would like.
Can't hear. You're muted, Dr. Shatabdi.
Yeah, I would like Sonia ma'am to kindly introduce Bharti ma'am and also introduce her talk.
Good evening. Thank you very much. With due respects of icons of Foxy members in this virtual platform, and thanking Chairperson Dr. Priyankur and Dr. Monica and Shatabdi for coordinating this webinar. We know that to achieve vision and a global strategy for women, children, and adolescent health, we need innovative evidence-based approach to antenatal care. And to enlighten us about the guidelines, please join me in welcoming our speaker, President-elect of Kasoga 2324, Dr. Bharti Rajashekhar. Madam has already decorated the post of Director in Hassan for Indian Red Cross, and she was IMA State Past Vice President, and she is member of AHPI Karnataka and Karnataka HSSC and Karnataka PCPND. She is a member of Foxy Public Awareness Committee, and she was the coordinator South Zone and Foxy Preventing Oncology Committee. Has also been an excellent teacher and a trainer, and she has flagged the first Foxy flag high in the state of Karnataka doing the Foxy Dhira program. She's bagged many awards to her credit, and one such is the Foxy President Rotating Trophy as Secretary of Hassan OBGYN Society. And to her credit, she has also had been awarded when she was the Secretary of Hassan Society and President, Dr. D.K. Tank Award twice. Congratulations to you, Madam. She has been a faculty in various state and national conferences, and here we are, Lady Beauty with brains, to present to us a vibrant topic. I think that is her topic of choice, the antenatal care. Over to you, ma'am.
Thank you. Thank you, Dr. Sonia, for that very flattering introduction. And without wasting much time, I think let us move to a very, very important spectrum of obstetrics care in our country. Because as you all know, we have achieved a lot in the past few years, but we have a long way to go to achieve the SDG goals of 2030. And I think if all of us obstetricians put our hands together and work with, as you said, evidence-based protocols, I think the day is not far enough when every single mother in India will live and we will not see any maternal deaths. We would try to bring it down lower than the SDGs. So I will be sharing my screen now. Just a minute, please. Yeah, it's open. It doesn't show the, how do I find this? Just a minute. Monica, I'm.
Yeah, ma'am.
Yeah, I think I got it.
Just double click on it.
I think I got it. Just to open, right? Yes.
Yeah, it is opening.
It's opening. I know it's a little slow. Anyway, for safety's sake, I have sent my presentation to Monica in case I have a problem. Actually, it's open on my desktop. I don't understand. Yeah. Now.
Ma'am, you close this screen,
Huh?
minimize it,
Okay.
then click on in Zoom, click on share screen once again. Then the presentation is showing open presentation. Click on that presentation.
The screen what we are seeing is with
Resume share. It says resume share.
Ma'am, we are showing your that Dr. B.R. Kasoga's folder.
Now you can see antenatal care, isn't it?
No, ma'am.
No, ma'am.
The screen what is displayed here is with a lot of PPTs.
Files.
I know. It's gone to the main desk.
Yeah, main desk.
Yeah.
I think you have to minimize it.
Ma'am, go to the Zoom.
Yeah, I'm on Zoom.
Yeah, I am sharing this current screen. Stop sharing. Then you again try to share, ma'am.
Stop share. Okay. Yeah, I've stopped sharing and then again I share.
Ma'am, click on share screen. That green button.
Yeah, that's what I've done.
Yeah. Now the different windows is visible. Click on that presentation directly.
Yeah, I know. I got it now.
Yeah.
I just had some problem. Yeah.
Yeah. Just play from start.
Yeah, play from start.
Play from start.
Yeah.
Yes.
I'm sorry.
Yes,
I'm sorry for that. Well, without wasting much time, as antenatal care is the basis of any maternal health program in India. And as you all know, it is the period of systematic supervision of women during pregnancy and to monitor the progress as well as and ascertain the well-being of the mother and the fetus. And it starts from the time of conception, I would say preconception now, to the onset of labor. And the aim of antenatal care is always to preserve the physiological aspect of pregnancy and labor, to prevent and detect all pathological disorders as early as possible, achieve a healthy mother and a healthy baby, and early diagnosis during pregnancy can prevent maternal mortality, fetal death, infant mortality, and morbidity. So this is so this is what we need to do, and it is a very critical part of our armamentarium. We need to give proper antenatal care to reduce complications, reduce stillbirths and perinatal deaths, and we need to give an integrated care of delivery throughout pregnancy. So what do these women want? So women generally want a positive pregnancy experience, which very often is sometimes not available. So a healthy pregnancy for the mother and the baby, she needs physical, socio-cultural normality during pregnancy, not considering it as a disease, effective transmission to positive labor and birth, and a positive motherhood, including maternal self-esteem, competence, and autonomy. I think this is a very, very heavy slide because very often we fail to identify that this is a normal transition of life. We need to give them a positive pregnancy approach. So Dr. Ian Eskew, the director of RCH WHO, said, if women are to use antenatal care services and come back in time to have their baby, they must receive good quality care throughout their pregnancy. Pregnancy should be a positive experience for all women, and they should receive care that respects their dignity. Because very often nowadays, especially, soon as they become pregnant, the parents, the in-laws, the husband, they think it's a disease. They don't even look at the mother as a positive woman who is healthy and is going through a normal transition of life. So the WHO has organized a series of recommendations to improve the quality of antenatal care, to reduce the incidence of stillbirths and pregnancy complications, and give women a positive pregnancy experience. By focusing on a positive pregnancy experience, these new guidelines will seek to ensure a healthy pregnancy for mother and baby, but also a smooth transition and a very good experience of motherhood, rather it being a scary, dramatic, and a sort of a nightmarish type of an incidence in her life. Because very often we see them, we don't want to have another child. I think one child is enough for us, because sometimes they feel that the transitional phase of the antenatal care and the labor process and the after birth care of the child is a little not negative in them. So we need to develop this positive attitude. So the objective, as you have told, I've already said, is to promote and protect, maintain the health of the mother, detect high-risk cases and give them special attention, very, very important in our country, to foresee complications and prevent them, to remove anxiety associated with delivery. So the WHO envisions a world where every pregnant woman and newborn has quality care throughout pregnancy, childbirth, and the postnatal. And they have come out this wonderful guideline of a positive pregnancy experience in 2016, which I will be highlighting. So they center around reducing mortality, morbidity. That is the base of every recommendation. Providing respectful care. I think this is where I think we are lacking in our country. We have to start trying to give them respectful care, because there are many reports we see the women, especially when they are in labor, they have a very tormenting and a very scary review of whatever they tell post-delivery. The attitude of the healthcare workers, the attitude of the birth attendants. I think we have to optimize the service delivery within our health systems. So earlier, the WHO had this focused antenatal care model, which has been modified in 2016, and I will be elaborating on that. So they came out with a recommendation which they identified that the earlier 4-visit ANC model showed increased perinatal deaths in women, and hence the WHO, after much deliberations, came out with a new model where they say 8 contacts are recommended to reduce perinatal mortality and improve women's experience of care. So evidence has supported that safety during pregnancy through increased frequency of there is an increased frequency of maternal and fetal assessments to detect complications. There is evidence supporting improved health system communication and support when they have 8 contacts. And there's evidence indicating that more contact between pregnant women and respectful, knowledgeable healthcare workers is more likely to lead to a positive pregnancy experience. I think we have to pick up this, because we need to train our ASHA workers and our health workers who are in the grassroots level to have a positive outlook to pregnancy. And evidence from a lot of studies indicate no important differences in maternal and perinatal health outcomes have been included when they have had more than 11 to 15 contacts. So what is this contact? The latest WHO guidelines removes the word visit. It says the guideline uses the term contact. It implies an active connection between the pregnant woman and the healthcare provider that is not there with when the word visit is used. So quality care, including medical care, support, and timely relevant information is to be given at this contact. Contacts can take place not just at the facility, but also at the community level. That is what the ASHA workers are doing in India today. It can be done in the village level, in the community level, in the Sri Shakti self-help group levels. We could provide them with knowledge about their pregnancy. And the contact helps to facilitate contact-specific recommendations like interventions for malaria and tuberculosis in context-specific areas where it is endemic, and also about the health system and the options available. So the contact word is what is new in the WHO guidelines, and the other one is antenatal care models should have a minimum 8 contacts are recommended to reduce. So this is one of the major changes which has shown that 8 or more contacts can reduce perinatal deaths by 8 per 1,000 when compared to 4 visits. So this is the WHO ANC model, where we have to have the first contact preferably at an earlier level up to within 12 weeks, second trimester 20 and 26 weeks, and then the third trimester we have to have more contacts, because we may anticipate more complications at this time like PIH or IUGR, preterm delivery. So 30 weeks, 34 weeks, 36 weeks, 38 weeks, and 40 weeks. Well, many of you may be wondering, this is what we are doing in our clinics. But unfortunately, the rural setup where women do not have access to the private setup, they do not visit the public facilities so frequently. So this option has to be available in all public sectors to every pregnant woman in our country. We need to see as Foxians that this happens through the Public Awareness Committee. And then she returns for delivery at 41 weeks if not given birth. And along with that, if she is in an endemic area, intermittent preventive management for malaria or HIV has to be started as early as 13 weeks. So it is not just enough to just follow and read the guidelines and sleep over it. Very important, we have to implement and disseminate this information. And that is why I think Foxy Public Awareness Committee is doing a wonderful job of implementation and dissemination. So what do we have to do? We all know that we have to do the standard maternal and fetal assessments. We have to look into nutrition during pregnancy. We also have to look into the treatment of physiological problems experienced during pregnancy. We have to take up preventative interventions in certain contexts, such as malaria and HIV endemic areas. And the recommendations on counseling and supporting women, we do have to talk to them about intimate partner violence, which I think most of us definitely do not speak about. We also need to talk to them about their sexual experiences. So we need to give guidance in all this in a comprehensive manner. So these were the recommendations by WHO. They have added the old recommendations. They had the earlier 10 recommendations. Along with that, they have added 49 recommendations into 5 groups. That is nutritional interventions, maternal and fetal assessment, preventive measures, interventions for common physiological symptoms, and health system interventions to improve the utilization of quality ANC. So these are few of the examples, a very exhaustive slide. So what do we have to talk to them about nutrition? I think each clinician has to spend a few minutes to talk to them or have pictorial charts, have a nutrition table, have the nutrition plate on our table and explain to them about healthy eating and keeping physically active during pregnancy. This is a very strong recommendation to prevent excessive weight gain. If we are busy in our clinic, I think we need to have an associate health worker who is trained to talk about healthy eating and physical activity during pregnancy. And I think in the Manyata and the Visit program, we are trying to achieve such things. So nutrition education on increasing daily energy and protein intake in undernourished women is recommended for pregnant women to reduce the risk of low birth weight. So that's a context-specific recommendation. In undernourished population, balanced energy and protein dietary supplementation is again recommended. But in undernourished population, just high protein supplementation is not to be recommended just to improve the perinatal outcome. So they have to have a balanced energy and protein diet. Then, of course, the daily supplementation of iron and folic acid, 30 to 60 milligrams of iron and 400 milligrams of folic acid is to be continued. Some women who do not tolerate this iron due to side effects, we can always give them intermittent oral iron and folic acid supplementation that is context specific depending on each individual. And we need to give them daily calcium intake of 1.5 to 2 grams is recommended in pregnant women to reduce the risk of preeclampsia more so. Vitamin A is not recommended routinely unless there is some sort of a context specific recommendation. Zinc supplementation is only recommended in the context of rigorous research, not routinely. Micronutrient supplementation is not recommended. Vitamin B6 is not recommended. Vitamin E and C is not recommended. Vitamin D is not recommended for pregnant women to improve maternal and perinatal outcomes. And for pregnant women with high daily caffeine intake, we need to lower their caffeine intake to prevent low birth weight neonates. So we see a lot of prescriptions with a lot of micronutrients and multivitamins. I think we need to retrospect on this. And of course, we do the full blood count rather than just the hemoglobin testing to diagnose anemias, not only iron deficiency, but other nutritional and hereditary anemias. We have to do a midstream urine culture to identify diagnostic asymptomatic bacteria in context-specific recommendations, not in all women. And always inquire about intimate partner violence should be strongly considered at antenatal visits when assessing conditions, especially if you feel that she's in depression or she has some injury on her body. I think we have to talk to them in confidentiality about intimate partner violence. And of course, hyperglycemia, we have all been talking about it. You have to screen for GDM by their DIPSI guidelines for all women as early as possible. Talk to them about stopping tobacco and alcohol abuse. And of course, in context-specific HIV screening with proper consent has to be taken and integrate the HIV management into the reproductive health management along with the proper antenatal care. And in settings where tuberculosis is prevalent, we need to do the screening for pregnant women in tuberculosis, and we have to integrate the management of HIV and tuberculosis into our own antenatal care, even GDM into our antenatal care, rather than just passing on the responsibility to the other part of our other colleagues in our fraternity. Of course, the fetal assessment will be daily fetal kick count is only recommended in the context of rigorous search. But of course, in this, I think in our setup, daily fetal movement counting does help us a lot. And replacing abdominal palpation with the symphysiofundal height measurement for assessment is not recommended. So the cryo whatever fundal height we could do could be adequate recommendation for us. Routine antenatal cardiotocography is not recommended just to improve the maternal and perinatal. It is only in context specific. When there is high risk, when there is IUGR, you feel it is a high risk pregnancy, then you can do routine antenatal cardiotocography according to the WHO guidelines. One ultrasound scan before the 20 weeks of ultrasound is 20 weeks of gestation is recommended to estimate gestational age, improve detection of anomalies, multiple pregnancies, and reduce induction of labor for postterm, and improve the woman's pregnancy experience is recommended. However, we all know that the inversion of the antenatal pyramid, nowadays we would always advise in facilities where it is available, to those who it is available, we would like to do first trimester screening as early as possible to prevent to detect early anomalies as early as possible if the opportunity is there. Doppler ultrasound is not recommended for pregnant women. It is only in context-specific cases. So whenever we do the routine ultrasound, we are doing this gestational age, detect fetal anomalies, and multiple pregnancies. And this, of course, along with the PSMA, we are utilizing the private-public partnership to do that. And of course, I'm not going to go through this. Antibiotic prophylaxis is recommended only in recurrent UTI. Anti-D immunoglobulin in context specific, you have to give at 28 to 34 weeks of gestation to prevent isoimmunization. And in endemic areas, preventive helminthic treatment with albendazole is recommended after the first trimester as part of worm infection. And tetanus toxoid, or the tetanus diphtheria vaccine, I would say, has to be given as earlier to prevent neonatal mortality from tetanus. And the preventive measures, of course, if there is malaria, we can always treat them with sulfadoxin and pyrimethamine. Oral, and when a HIV positive patients, we would continue the PEP program for along with the antenatal care. And then for the recommendations for the normal physiological problems that our women do have, like heartburn, nausea, vomiting, leg cramps, ginger, chamomile, B6, acupuncture are recommendations for relief of nausea. Advice on diet and lifestyle along with antacids for heartburn in pregnancy. Magnesium, calcium, or non-pharmacological treatment can be used if they have leg cramps. It is recommended. Regular exercise is recommended to prevent low back and pelvic pain. We have to talk to them about this, give them charts, and see that they continue, because every woman who walks into our antenatal clinic will always be complaining of low back pain and pelvic pain. They just want medications. So rather than medications, I think we should go for non-pharmacological methodologies, which is recommended also. And for constipation, let us use wheat bran, other fiber supplements to prevent her constipation. And of course, non-pharmacological options like compressive shockings, leg elevation and exercises, water immersion for varicose veins and edema, which are very common physiological problems we come across. Then how do we enroll and take the health system along with us? This is what India has to mobilize. We have already mobilized. We need much more to mobilize in this. It is recommended that each pregnant woman carries her own case notes during pregnancy to improve continuity, quality of care, and her pregnancy experience. I think this every obstetrician should do, because very often we have seen certain clinicians who do not hand over the antenatal records to the pregnant woman. They keep it in the hospital. It becomes very difficult for that lady when she has a continuity of care or she's traveling. So she needs to be carrying her records. Midwife-led continuity of care models have to be known. And so the midwives support the woman throughout the antenatal, intrapartum, and postnatal period. So we need to train our midwives to take up this comprehensive program in the context-specific situations. And group antenatal care was something which was very interesting, I found, where we have a qualified healthcare professional. She is giving a group antenatal care on certain days. So we talk to them as a group and we clear their doubts, and we do the labor management protocols we talk to them about. We talk to them about the baby. We talk to them so that our infrastructure and resources can be delivered to the group. And I think in HSOG, I would like to say that we do these group antenatal, and of course in this Pledge to 9 program of our PSMSA, many of our obstetricians have taken up the program of doing group antenatal care, which definitely will go a long way in helping our pregnant women. So this community mobilization, not only with the healthcare personnel, we have to utilize women's groups, we have to use peer groups, and we have to use the NGOs so that we can give them community mobilization programs and packages of interventions that include household and community antenatal visits will definitely help us, especially in the Indian scenario where transport and reaching the primary healthcare center is sometimes very difficult. Then task shifting the promotion of health related behaviors to the health workers. Nurses, midwives, and doctors is recommended. And task shifting, so they share the task with not only healthcare personnel, but even broad range of other cadres, especially in management of malaria. And the policy makers should consider educational, regulatory, financial, and professional support to recruit and retain qualified health workers in rural and remote areas. I think in India, our health ministry has to wake up to this, because we are finding that in many remote areas, we do not find qualified healthcare workers, qualified obstetricians and gynecologists, because the support they receive from the government machinery is not feasible for them to stay in such setups. So I think we need to change the scenario in India. So how can we change? We know that the Pradhan Mantri Surakshit Matritva Abhiyan has been launched and is doing a wonderful job, but we need to do more. You all know that free of cost antenatal care is provided on the 9th of every month in all public health centers, and a lot of private health centers have also tied up with them. We provide a guarantee minimum package of antenatal care to them, and they follow a systematic approach of engagement with the private health system. So this is what a lot of changes which are occurring in our country and have contributed to the decrease in the antenatal care. So there's a free day, fixed day for ANC services. Ashas and ANMs prepare the list and bring the eligible women. Special ANC checkups by obstetricians, private and public, and focus women in second and third trimester and identify the high risk. This is the charter. I'm not going to go through the details. The strategies are very well planned out. Antenatal visits, advice, prenatally, health protection for specific problems, mental preparation, family planning, and the pediatric component is not to be given up. So these are the visits we are supposed to do. And we are going to do the routine antenatal checkup as all of you are doing. History, physical examination, blood examinations, and the necessary tests to be done. And we provide them with iron and folic acid, immunization, group instructions, home visiting by the health workers, and referral services whenever they are there, and inform the woman about the Janani Suraksha Yojana and other incentives offered. So I'm not going to go into all these details. We know the antenatal care, all of us are doing it. The one point I would like to stress here is screening for GDM by the DIPSI one-step test is mandatory at the first visit of every antenatal mother, because very often we are seeing that they are doing it at 24 or 26 weeks, or they miss out on the GCT. They are only doing the random blood sugar, and we fail to pick up many of those women who are not only going to have risks in this pregnancy, they are causing risk to the unborn fetus too, and the future generation. So I'm not going to elaborate on that, but I just want to tell you, please do not the one-step glucose test, please do the one-step OGCT test along with your other routine tests that you're going to do. And this one ultrasound scan before 24 weeks, I already told you, but here I would like to reiterate that now we are going back to inverting the antenatal model, and that is what they say, that by doing earlier scans, we can identify starting screening as early as possible so that we have a higher possible detection rate. So I would say that the 12 weeks evaluation of the women by ultrasound for all the markers have to be universally implemented. And of course, this has already been spoken about, and we need to talk to them. See, most of us do prescribe iron, calcium, folic acid, all that we are talking, but we are not talking to them about personal cleanliness, about their exercise, about their dental care, about sexual intercourse, birth preparedness, warning signs. We do tell them child care also. Very often we do not prepare them for childbirth and childcare. I think we have to have charts. We have to spend some time, have a group antenatal class and talk to them all these and see that they are clear about it. So according to the PSMSA, the high-risk cases have to be identified with a green sticker if they are no risk, a red sticker, women with high-risk pregnancy, and they are all the high-risk women are to be referred according to the protocol to the higher centers. and the warning signs have to be informed to them, so that when they come with this card, the records are maintained. They come with a green sticker. We know there are no high risk factors. They come with a red sticker. We know this is a high risk. She needs special care. So this case record is to be handed over to the women and instructed to bring during all the subsequent visits. And this contains a registration number which has identifying data, and definitely she can be tracked by the Ministry of Health and Family Welfare. So we have made leaps and bounds in the past 20 years. The maternal mortality, which was in 400s, has declined to 130 per 100,000, and in few states it has gone less to the SDG goals we have achieved, especially in the Kerala, Maharashtra, Tamil Nadu, Telangana, and Andhra Pradesh. They have reduced to less than 70, but I think we need to reduce the numbers further. And the other states are still there, but we have a lot of states are still lagging behind according to the 2020 census. We still have states, especially the Northeast, where the incidence is as high as 200. So this is where I think the FOXI and the Public Awareness Committee, we need to focus and see that all these maternal healthcare interventions by the Government of India as well as by the WHO are implemented, so that we can bring down the maternal mortality, because there are various lacunae that we are seeing in this system. What is the lacunae? According to the NFHS data, you see that mothers who have had their checkup in the first trimester is not just 75 to 6 in the rural urban areas, and around 68 in rural areas, and mothers who have consumed iron and folic acid. Because, you know, anemia is a big demon in our pregnant women. It is only 54, and in the rural, it is only 40% who are taking iron and folic acid. However, the tetanus toxide is almost reaching 100%. So there are some lacunae which we need to address. So we have to take into consideration that low and inequitable utilization is there. It is imperative to design strategies in order to achieve the WHO recommendations at the earliest. So what are the solutions? What I would put across is steps to strengthen universal coverage of ANC. Women's education and empowerment and autonomy is very important. Social marketing of government schemes and programs on social media is very, very important. We need a stronger public-private partnership, and I'm sure FOXI can achieve a lot through this, so that we can see that their SDG goals are achieved, especially in those states which are lagging behind. And mass media and social media, we know, has an excellent take-up by our youngsters especially. So we need to propagate planned motherhood to these young couples, counsel the married couples for planned parenthood, broadcasting important messages related to antenatal care at relevant health and educational institutes through mass media. I think we need to go to the colleges and schools and talk to the women who are going to be the future mothers. So we need a coordinated effort is needed from different sections of the government involved in delivering maternal care, along with the private practitioner, the FOXI, the Indian Medical Association. So and there's one more suggestion I would try to say. In the Ayushman Bharat scheme, if you see, the maternal reproductive healthcare system, the services are not included. They are all the primary and secondary care, and they are not involved in the Ayushman Bharat. So I think, Priyankur, we need to go to, along with FOXI, with Dr. Rishikesh Pai, to the Ayushman Bharat and ask them to include the reproductive health scheme deliveries, antenatal care, as well as maternal care into the Ayushman Bharat scheme. Unfortunately, it is not there. So let us all try to give quality antenatal care. Let us all pledge for 9 and see that every woman in India is saved. And how do we save them? Always together. Everyone, when we are together, we can definitely achieve more, so that every woman goes home with a healthy baby. I thank you very much for your patient hearing. So let us try to provide pregnant women with respect, individualized, person-centered care at every contact, with implementation of effective clinical practices and provision of relevant and timely information and psychosocial and emotional support by practitioners with good clinical and interpersonal skills, with a well-functioning health system. I thank you very much, and namaste to all of you.
Thank you so much, ma'am.
Thank you.
That was a wonderful lecture. I would request Suchitra ma'am and Sonia ma'am to kindly conclude the talk by Bharti ma'am.
Dr. Bharti, that was a wonderful talk. All encompassing, very comprehensive, and really excellent.
Thank you, madam. Thank you, Dr. Suchitra.
Yes. And in Kerala, as you say, that we have a very, we have the least mortality rate, because it starts from the basics, because most of the women are educated, and we have regular adolescent health awareness classes. where girls are told about the reproductive system, etc. And also we have antenatal classes, including the relatives. We take the mother-in-law also to sit with them, antenatal and postnatal classes, so that they are the people who sometimes hinder the actual healthcare with all their superstitions and things like that. So the diet, everything is given to them like that. So really, I think if we all go forward hand in hand, we can have a wonderful, we can really reduce the mental rate and stillbirth rate.
Yeah, I think Dr. Suchitra, we will carry home some messages from the Kerala model. And as you said, we also do it in a small way. I think more extensively, we have to do the adolescent health education, which I also always believe in, that if we educate them young, we catch them young, we can have a brighter future.
And also very obese adolescents are there. So if we start some physical exercise like Zumba or something that makes them shake up,
Community programs, yes.
Community programs. So that will decrease the number of cesareans also, I think.
Definitely.
Congratulations, Madam Dr. Bharti Rajshekar, and we look forward as a president-elect.
Sure.
There are a lot of things to, as you mentioned, implementation and dissemination. I think we all OBGYNs join hands together. Also, I would definitely agree to you with the promotion of group antenatal care, which is very advantageous, as you have mentioned. And as the statistic says, it is 88% of the women who's receiving antenatal care, the contact, what you said from the visit, we rename it to as contact. And otherwise it was just 66%.
Yes.
And now I think we all OBGYNs under the platform of Foxy, we will bring down to at least 90% down the line with these webinars and sharing. Thank you very much.
Whatever achievement has been done, I would say it is because of all our Foxygans all over India, but we need to do a little more.
Thank you very much.
Thank you, Sonia and Dr. Suchitra. And Dr. Monica and Priyankur, thank you very much for the opportunity.
Thank you so much. Thank you once again, Bharti ma'am.
Thank you, Satabdi.
Thank you, ma'am. Thank you, Sujitra ma'am and Sonia ma'am, once again for chairing the session.
Thank you.
We'll move on to a very interesting panel discussion coming up. Our next session is a panel discussion on perimenopausal AUB in perimenopausal age group. We have two dynamic moderators with us. We have Dr. Jairani Kamraj ma'am and Dr. Niharika Allu. And our expert for the session is the ever dynamic Dr. Sheila Mane ma'am. Can we have the slides, please, Abhishek? Yeah, Dr. Jairani Kamraj is one of our moderators today. She is a senior consultant of reproductive medicine and director at Akash Fertility Center and Hospital at Chennai. She is the president of Oxy as well as the treasurer of Tapisar, also the associate secretary for the World Association of Sexual Health Advisory Council member and World Association of Sexual Health. Welcome, Jairani ma'am. Looking forward to a great session. Our next moderator is Dr. Niharika Allu. Ma'am is a consultant obstetrician and gynecologist at Birthright by Rainbow Hospital at Visakhapatnam. She is the secretary. She is the secretary of OGSY 2023-24 as well. She has been the joint secretary in the last year. She also has been the member of Public Awareness Committee in 2021 to 2023. Welcome, Dr. Niharika. Our expert for the session is Dr. Sheila Mane, ma'am. Dr. Sheila is currently a DNB faculty at KCG Hospital, Bangalore. Ma'am is an ICOG Governing Council member, president of Isoparp Society of Bangalore, as well as the president of Bangalore Menopause Society. She also has been involved in academic programs and workshops for postgraduates and Foxians. Welcome, Sheila, ma'am.
Thank you. Can you ask them to allow me to open my video to the organizer?
Yes. Yeah. Yes, ma'am. Abhishek, please look into it. No, allow Sheila ma'am to open her video, please. Yeah, we have an excellent team of panelists today. Our first panelist is Dr. Parvati Deth. Abhishek, slides, please. Yeah, Dr. Parvati is an associate professor in Department of OBGY at Government Medical College, Ernakulam. Also the editor of KOFAG Journal, as well as she has been the vice captain of MDMNSR, Ernakulam District, Kerala. Welcome, Dr. Parvati.
Thank you.
Our next panelist is Dr. Shobha, ma'am. Dr. Shobha is a consultant at Sanjeevani Hospital at Bagalkot. She also is the secretary of the Bagalkot Obs-Gynae Society. She has been the past secretary of Critical Care Committee of Kasoga, as well as the chairperson of Safe Committee, Karnataka. Welcome, Dr. Shobha. Our next panelist is Dr. Shamina ma'am. Ma'am is a senior consultant in obstetric and gynecology as well as IVF at Aster Medicity, Kochi. She is the fellow in RCOG, MNAMS, FICRS, DNB, as well as MRCOG. Welcome, Dr. Shamina. Our next panelist is Dr. Suma Vishnu ma'am. She is a consultant obstetrics and gynecology at Vinayaka Hospital at Wayanad, Kerala. Also the founder, treasurer of Wayanad Obstetrics and Gynecological Society. Welcome, Dr. Suma ma'am.
Thank you so much.
Yeah, our next panelist is Dr. Radhika Gauri ma'am. Ma'am is a specialist consultant in OBGY and clinical lead at ESIC Hospital at Tirunelveli, Tamil Nadu. She has been a Tanjore alumni and DGO at MMC Chennai. She also has her MRCOG. She has more than 20 years of clinical experience in OBGY. Welcome, Dr. Radhika ma'am.
Thank you.
Our next panelist is Dr. Padma ma'am. Dr. Padma is a visiting consultant at Apollo Viha and Spandana. Currently, she's more into the menopause medicine. She is the current treasurer of the Chennai Menopause Society. She has more than 23 years of experience as an obstetrician and gynecologist. Welcome, Padma ma'am. Our next panelist is Dr. Mehvish Anjum ma'am. Ma'am is a professor at KBN University, Faculty of Medical Sciences at Kalburgi, Karnataka. As also the consultant at Afeya Maternity and Children Hospital at Kalburgi, Karnataka. She has an experience of more than 13 years and is a recognized UG and PG teacher. Welcome, Dr. Mehvish.
Thank you, ma'am.
And last but not least, we have Dr. Shubha Ramarao, who is the president of BSOG. She is a senior of Department of St. Martha's Hospital. She is a DNS guide and and she has been faculty at various national and international conferences. Welcome.
Thank you, Dr. Shatabdi.
Yeah. Yes.
Thank you, Shatabdi.
Yeah. Over to you.
Thank you, Shatabdi. Thank you for the nice introduction. And me, Dr. Jairani Kamraj, along with Dr. Nigarika, will be moderating this panel on AUB in perimenopausal age group. A very special thanks to Sheila Mane Madam for being here to be an expert for this panel. And we have a wonderful panel of around 9 panelists who are very senior, a mixed bag with a lot of seniority, experience and expertise. And we'll be now talking on this important and a very interesting and a very day-to-day. Can you see my slides?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Okay, can I go like this or should I?
Ma'am, you go like this only. Slideshow will not be possible.
It's not seen? You can't see that?
Exit the slideshow, ma'am, please.
My video is still not opening.
Ma'am, Sheila ma'am, I have sent you the notification
Yeah, I
to
am
start
clicking
your
on
video.
that. No,
Yeah.
I have
Can you see the full slide or?
No, ma'am. We are seeing the older version also only. You just share screen again, ma'am.
Okay.
I am not able to open my video in spite of your.
This is okay.
Ma'am, you need to Sheila ma'am, you need to log in again, ma'am.
Can you see right now? Can you see right now?
Yeah, ma'am. We are seeing right now. Click on the next slide. Click in between and click on next. Yes, your CV is visible.
Okay. Can you see? Yes.
Niharika ma'am CV.
Yes, ma'am.
Okay. So I'll go like this. Am I right?
Like this, yeah.
Yes,
okay.
ma'am.
So, thank you for this support, and very sorry for this technical difficulty. So we know that perimenopause is the very important period in a woman's life, which ranges from 42 years to 52 years, a period which starts 2-3 years before the menopause. And this is a very important stage in the women's life where the endocrinological, hormonal, biological, all the changes happen in the women, along with a lot of changes in her reproductive system, and that leads to many important conditions, gynecological conditions women go through, which is a very important step to bring her a lot of difficulties, lot of stress, and decreases her quality of life through many of the depictions of this hormonal and the biological changes which happens during this perimenopausal period. If you look into the perimenopausal period, the important problem women go through is the AUB, which is almost 1/3 of our outpatients in the gynec department is always AUB in a perimenopausal age group. Only women, if you look into her history, at least once in her lifetime should have gone through an AUB episode. And more than 3 times, many women, up to 78%, go through some form of an AUB. That is an abnormal uterine bleeding they go through, which really poses a challenge for the gynecologist to treat her, to evaluate her, and to correct her, either with a medical treatment, put in the diagnosis, treat her in the proper way. Because many a times, the only answer from the patient is, doctor, do I need to remove my uterus? That is the first question they will be asking you. But at this era of Save the Uterus, we gynecologists should be aware of what are all the modalities of treatment that we have for the different group of these people, these women, how we are going to treat her, how we are going to evaluate her, guide her in the right way, correct her problem, and give her a good quality of life is a real challenge, which is make the lives very interesting. And it is really interesting for gynecologists to work on this line. So we are definitely have a very important role of a proper evaluation of this patient, give her a good, correct diagnosis, and also give her the best possible treatment, which is usually non-invasive as people want more, maybe a medical treatment or a surgical with less invasiveness. And if needed, we may have to give the proper surgical correction. And very important, we need a lot of counseling, because many a times they will be very much stressed with these conditions and they need a lot of counseling. And also you need to create an awareness among the women, because many go through this process in a very, very, very difficult way, and to end up in a menopause, they'll be happy to stop the bleeding at some point of time. So we need a lot of awareness and create the very important conditions, and whatever possible, the best thing that we have to work for this patient. So let me throw my first question to Dr. Parvati. Can you define what is the abnormal uterine bleeding by definition, and how it can be presented as described by the FIGO? Can you just let all our delegates know about the definition for the abnormal uterine bleeding? Parvati, are you here?
Yeah, can you hear me, madam?
Yeah,
I'm
please.
audible.
Yes.
Yeah. It's a bleeding from the uterine corpus that is abnormal in its regularity, volume, frequency, and duration. That is the 4 characteristics with which we describe a menstrual cycle. So any deviation from its regularity, that is, it may be from then latest what we say is from 24 to 38 days, volume of more than 80 ml, or of frequency that is more than 10 to 19 days, or a duration of more than 8 days. All these comprise AUB roughly.
Yeah. So you're right. It may be an irregularity both in the volume, frequency, duration, and also there should not be associated with the pregnancy. So how it can present? Can you tell me still more in a better way how much you calculate the amount? Because many times the women will come and ask you, ma'am, my bleeding is so heavy, hardly should have soaked one pad. Or she may be throwing 5-6 pads, but that will be hardly a few drops. So can you have any measures by which you can tell her, convey her what type of a bleeding she has and how much is her bleeding? Can you explain still more in that, Dr. Shobha? Can you explain that?
There's a scoring system for assessing the uterine bleeding, menstrual bleeding, because each patient's expressions are so different. A patient who has heavy bleeding can take it as a normal bleeding, and a patient who has light bleeding can explain it as heavy bleeding. So there's an objective scoring system. In this system, one tampon, like if the patient is using a tampon, if it is lightly stained, it is scored as 1. If it is moderately stained, it is scored as 5. And fully soaked tampon, 10 scoring is given. If there's a clot, a small clot is 1 score, and a big clot is 5. So we can sum them up, and score more than 100 through the cycle is called as heavy menstrual bleeding. The same applies if the patient uses a pad. If it is lightly stained, it is 1. If it is moderately stained, it is 5. And it is completely soaked, it is 20.
Yeah.
So score of more than 100 is significant.
So that's great. So definitely there is a FIGO system. When they come across this abnormal uterine bleeding, they always suggest what is normal and what is the limit of the menstrual parameters for the uterine bleeding. They calculate according to the frequency which may be frequent, normal, infrequent when they calculate the time limits, and also the regularity they calculate. And with the duration, they calculate as a prolonged, normal, or shortened. And with the volume, they say heavy, normal, light. So that is the FIGO system. So this is a very important thing that we have to look into the patient when you plan the treatment proper. So in this way, the AUB has a changing concepts of earlier we used to say epimenorrhea, menorrhagia, epimenorrhagia, hypermenorrhagia. All these things has been changed by the new FIGO classification. So, can I ask Dr. Shamina to say what is the latest FIGO International Federation classification of AUB? Depending on the causes, they have given some classification which is very useful for the clinical approach. Can you elaborate on that?
Yes, Dr. Jairani, it is a palm coin classification where the palm stands for the structural causes and the coin part stands for the non-structural causes. The structural causes P for polyp, so it is classified as AUBP, that is a polyp with the causes polyp, and A for adenomyosis, L for leiomyoma or the fibroid, and M for malignancy and hyperplasia. And the non-structural causes, it can be the coin, that is the C for coagulopathy, and O for ovulatory disorders, E for endometrial related problems, then I can be a iatrogenic causes, and the last one comes as under not otherwise specified. So our aim is to stratify the AUB into these different categories. Different
yes.
causes.
Yeah, you're right. So definitely that is a good way of FIGO classification. Can I ask Dr. Radhika Gauri, can you tell me, with this bleeding patterns, can you come across some form of a diagnostic criteria which can correlate with the clinical classification, which can correlate with the classification? Can you enlighten on that, you, Dr. I think Subha Vishnu, can you ask this question? Can you answer this question?
Yes, madam, definitely. Yeah, clinically, even though we have this FIGO classification, clinically, when a patient approaches us, we'll get symptoms like it can be broadly classified into cyclical and non-cyclical. At times, the cycles may be regular, but she may get a heavy cycles. So we can categorize it into heavy menstrual bleeding. And it can be cyclical, but definitely there will be some intermenstrual spotting. So that can be a second group of classification, like which categorizes to intermenstrual bleeding. And the other one is non-cyclical, because she may get bleeding on and off. She cannot tell when she is going to get bleeding. So it is totally a non-cyclical. So that can be separately classified because the etiologies can be different. So clinically, we can grossly classify them as cyclical and non-cyclical. And when we talk regarding cyclical, it can be categorized into heavy menstrual bleeding, and our gross FIGO classification, the initial parts like fibroids, adenomyosis, submucous fibroids, everything come under this heavy menstrual bleeding, even coagulopathies too. And with regard to the intermenstrual bleeding, the polyps can very commonly present with intermenstrual bleeding. Even some non-specified causes can also come under this category. Even cervical causes, cervical erosions, that too present with intermenstrual bleeding. And the 100% non-cyclical causes can be due to some hormonal issues, and even a malignancy can be a reason. So in the perimenopausal age, all these things should be kept in our mind when a patient comes with AUB.
Yeah, so that gives a broad holistic view of the AUB. It's probable the classification, the presentation, and the severity with which it presents, and thereby you can come to a conclusion of what are the problems it can create in the women individual, in the family, as well as how this is causing a lot of effect on the economical conditions of the women also. So with this, we can have a good platform to look into the patient, to find out the cause for the bleeding, and make what are the decision making regarding her treatment. What is the thing that we are going to look into her morbidity? What are the associated medical things she has, and how we are going to treat her, and what are the cost effectiveness and relative effectiveness, which is very important for our treatment plan for every AUB women. So with this, I think we can move on to case scenarios, which will give us an idea of how we can plan each case wise. Nigarika, can you take up from here?
Yes, ma'am. Thank you, Dr. Jairani. And at the outset, I would like to thank the Foxy Public Awareness Committee for this opportunity. So let's delve into the first case scenario. So this is, I think, a very, very common scenario that we see on a regular basis. A 42-year-old woman who's come to you with heavy menstrual cycle for the past 10 days after a period of secondary amenorrhea of 90 days. So this is a patient who has a PCO. She is a known case and she conceived with IVF. She has twin pregnancies and she's always had these irregular cycles. So on examination, you've not found much. So you've asked for a TVS and it shows that the endometrial thickness is 25 and there are no structural lesions. So how would you manage this case? Can I ask Dr. Radhika Gauri to take up this question? How would you proceed further?
Hello.
Yes, ma'am.
So the first step I would do is
Radhika, can you increase your volume? You are not that audible, or come close to the mic.
yes, ma'am. Hello, ma'am.
No, still your volume is low.
Okay, sorry, 1 minute. Abhi. Abhi.
You can put your mic close, ma'am, so that we can be better audible.
Okay. Hello.
Yeah, much better.
It's better, ma'am. It's better.
Okay. Thank you. So the first is I will take a detailed history regarding the pattern of bleeding, and can you please show the slide now? The case was amenorrhea.
Yeah, so she has 90 days amenorrhea.
Yeah, so we have to first think of pregnancy.
Very good.
I'll do a urine pregnancy test first.
Yes.
And then, so after the urine pregnancy test negative, depending on that, then we'll have to go about the case. So the next thing is because she's at, I'll do a physical examination and then the initial assessment and then the investigation, obviously the complete blood count, because she could be anemic. So we have to rule out those basic details. And then the thyroid, hypothyroid, we have to rule out. And then the BMI, I'll check for her BMI, if she's overweight because of PCOD. And then we have to look at, because the thickness is quite high and she's at risk of hyperplasia because of the polycystic ovary. I would immediately do a, I mean, after if the pregnancy test is negative, then I will arrange for a hysteroscopic biopsy or an endometrial pipple, outpatient pipple biopsy also. And I'll send that for histology. And
okay. So definitely what you said is right. You have to always rule out the pregnancy, and with PCO, always look out for hypothyroidism. And you're right that we would need a sampling, but would you really need a hysteroscopy? I think we will come to that a little later on. So can you just elaborate, Dr. Dr. Padma, on what next we will do? What other imagings would you need? Do you need anything further in this case?
In our current setup, we don't. The vaginal scan shows an endometrial thickness of 25 millimeter. So
Yes.
the next what I will do is an endometrial sampling. Either it's an office procedure, either as an office procedure, or I will ask the patient if she is comfortable with an office procedure or in a or with my small anesthesia. I will do an endometrial sampling with a pipel or a probate, and then depending upon the histopathological examination, I will proceed further.
So can you just elaborate on the indications when which are the patients where you would suggest sampling?
If the patient's endometrial thickness in a vaginal scan is more than 12 millimeter, I will suggest a sampling. And if it is a perimenopausal woman, it is like more than 12 millimeter. And in this patient, it is already 25 millimeter. So I will
Yes.
suggest a sampling. And in a postmenopausal woman, if it is more than 4 millimeter, I will do a sample.
Yes.
biopsy, endometrial biopsy.
Yes. And I would also like to add that I know we are discussing perimenopausal, but always be on the lookout for endometrial hyperplasia in PCO patient, even in younger women, because even a 25-year-old can have endometrial hyperplasia. So, Dr. Bhavish Anjum, do you think this sampling is enough for the diagnosis, or do we need to do any further tests?
Traditionally, we used to do DNC, but now we have better options like office endometrial biopsy, which gives very good results in terms of sensitivity. Like
Yes.
sensitivity for C endometrium is around 67 to 96, which is quite good. And in 87 to 96% of patients, we get adequate specimens also. And
Yes.
it has got a very good accuracy with all devices, especially with people. And
Yes.
CA endometrium sensitivity is as high as 96.6%. But we have one more gold stand. Different devices that we have is Pipple, Carmen's cannula, and a Vibra aspirator. But best is Pipple because it is very small in size. Then we can use Vibra aspirator also, by which we can attach it to a suction machine and get the whole endometrial sample. But the gold standard in these patients is the office hysteroscopy, because it's always better to see and take the biopsy rather than a blind procedure. And we
So
have
let me
very
just interrupt. So in this particular case, would you need an office hysteroscopy? In this case, it is just a PCO patient, and TVS is not showing you any structural lesion. It is just a 25 millimeter lining.
Can I come in, Niharika?
Yes, yes, please.
Yeah, I think as everybody is saying, I think hysteroscopy in this case, as we have done the TVS, and the sensitivity and specificity of TVS is good, you know. Like if
Yes.
we have a doubt, we could have put the Doppler also.
Exactly.
And she is having a heavy menstrual bleeding, right?
Yes.
So yes, I think if we want to rule out only hypoplasia, okay, but the patient who has a 25 millimeters thickness of endometrium and who is bleeding, I think it is even better to do a dilatation and curettage, because that hypoplastic endometrium has to come out. Okay, then only the bleeding will stop. Then,
Yes.
and the same thing can be sent for histopathology. It will be therapeutic as well as diagnostic, because if you look at the endometrial thickness, and as you pointed out, that hypoplasia is very common in PCOS patient. Even it could be atypia also. Okay.
Yes. Yes.
Recently, I have a patient who came for infertility, PCO, and it turned out to be atypia.
Yes,
So
ma'am.
she's only 27-year-old. So we
Yes.
have to be very careful nowadays, because I mean, atypia is seen even in younger age. So in this case particularly, I feel dilatation and curettage will be both therapeutic and diagnostic.
Yes.
I think what the panelists can
Yes,
say.
yes, ma'am. Yes, ma'am. We agree with you, ma'am. 100% we agree with you, because definitely she can have a polyp which can be a small focal thickening, which may have a place of an atypia or a hyperplasia with atypia. So definitely she needs a dilatation and curettage with a hysteroscopic guidance, which will be definitely giving us much information about this patient. So
Yes.
Nigarika, can the diagnosis came as a endometrial hyperplasia without atypia.
So how would you proceed? Can I have Dr. Shubha Ramarao take up this question?
Yeah, thank you for having me on this panel. And before I start answering this question, I had one how to assess the heavy menstrual bleeding. If a lady is using the menstrual cup, you know, it is an objective assessment. How many times she empties the cup will also tell you how much bleeding she has. So that way we can assess the amount of bleeding. Okay, now coming to the management for endometrial hyperplasia without atypia, this lady is in the perimenopause group, and because there is hyperplasia, she definitely needs some progesterone. She has excessive estrogens in her body, which is caused endometrial hyperplasia. And we all know this WHO classification. It is just hyperplasia with or without atypia, and there is nothing in between. So she needs progesterones, and the way you are going to give progesterone, you have to decide. I mean, initially, practically, I would start with medroxyprogesterone acetate, starting from day 21 of the cycle for about 5 days, and see how the response is. If she does not respond to that, we start earlier in the cycle from the 16th to 25th day. or she may need it because of the hyperplasia. We may even have to start from the day 5 of the cycle. And the progesterones can be, if it is acute phase bleeding, you use norethistron and you follow it up with medroxyprogesterone. The other way to deliver progesterone is putting the LNG intrauterine system, which of course is the grade 1 recommendation, but I wouldn't put it at the first go, because by giving progesterones, you're going to probably thin the endometrium, and then when you put the LNG IUS after 2 or 3 cycles, she responds better. Otherwise, she keeps on coming to you with irregular bleeding. So practically, that's how I do it. And LNG intrauterine system is the best for endometrial hyperplasia without atypia. And follow-up, you may have to do a pipple biopsy maybe 6 months later to see whether there is regression of the changes.
Yes, yes. Very rightly said. So, can I have Dr. Parvati tell me about the risk? I think the minute you say hyperplasia, everybody in the family starts going into a panic mode, and they're like, okay, fine, she's 42 years old. I don't think we want to take a risk of cancer. We want a surgery and all of that. So, can you really tell us what is the risk of CA endometrium, Dr. Parvati?
Around 20 to 30% the risk of C endometrium, especially if you're going for a blind biopsy, not a visualization. Right.
Without
Hello.
atypia, without
Okay.
atypia.
Without atypia.
It is less.
1 to 3, 1 to
Yeah.
5%.
Less than
It's less
5.
than 5.
Pre-
It's less than
Yeah.
5 over a period of 20 years. So you really can reassure them, tell them that it can be very, very easily treated. Only thing is they have to be on surveillance and on a regular follow-up. And I think LHG does a very good job of prevention also for a very long period. It's a long-term solution. Yes, please go ahead, madam.
So, Shobha, will you advise surgery? How you follow this patient? Madam said that she's a case of endometrial hyperplasia without atypia, and you are very sure that she doesn't have a risk of CA only less than 5%, but still, you have to counsel her about the follow-up. How you are going to counsel her, and who are all the patients that you will be advising surgery, and if so, what type of surgery? Can you elaborate on that, Dr. Shobha? Shobha, are you there? Shobha, if not,
we are not able to hear you. Dr. Shobha, we are not able to hear you.
Shobha, I think you're there, but increase your
She's
volume.
mute.
Yeah, you're unmuted only, but cut off your video and then go for the audio alone. Maybe your network is slow. Yes. Can you? Yeah, we can't hear you.
Hello, am I audible,
Yeah.
madam?
Yes.
Sorry, the network went down. It's actually raining here. That's the problem. So without atypia, we should not be so worried about that risk of CA endometrium. It roughly comes around, say, between 1 to 5%. But if it's with atypia, the scene changes. It can be between 20 to 40%. So that is how we should counsel the patient. And especially with a strong history of PCOS, with history of irregular cycles, we should be on constant watch on this patient. Regular follow-up is very essential in this case. Just by giving a progesterone therapy won't be suffice. We should counsel the patient that if such symptoms recur, there is always a chance that she may need repeat investigations.
Yeah.
Yes. So
when you will advise surgery?
Pardon, madam?
When you will advise surgical treatment, anything she will advise surgical treatment?
So if she has recurrent episodes, or if she's having endometrial hyperplasia with atypia and she's not so keen on, she already has 2 kids, so she may not be so keen on retaining the uterus, because after hearing a risk of 20 to 40% chance of CA endometrium, 42-year-old lady, family completed with a history of PCOS, and we haven't been told about the blood investigations. We don't know if she has a history of diabetes or anything. So if there is a presence of risk factors, I think we'll better advise her on surgery.
Yeah.
With the HPR report of atypia.
Yeah, you're right. So we don't advise surgical treatment as the first line, but it has to be given only for patients who are at the risk, like an obese who had a repeated attacks, or you who was not coming for a proper surveillance, and who has a family history of any malignancy, and also who are not getting control with your routine medical treatment, and of course, when they go for an atypia progression. So these are all the conditions where you intervene for the surgical treatment. So this biopsy has come as an endometrial hyperplasia with atypia, the same patient. How you are going to manage? Can I ask Dr. Shamina?
Thank you, Dr. Jairani. This case, if it has come with endometrial hyperplasia, again, she's 42 and she has completed the family, but then we have to sit with her and discuss the risk. So the risk changes to about up to 20% in this case. So still, they can opt for a they can opt for a medical management with progestogens or LNG IUD, but then a strict follow-up with the biopsy should be advised. Otherwise, if they are not coming for follow-up, or first thing we should advise should be the hysterectomy in this case, in perimenopausal age group, considering the high risk for endometrial CA. Only when she's insisting on keeping the uterus, we can go for the other options.
What about the ovaries?
Ovaries, yeah, the chance in endometrial hyperplasia with atypia, we can preserve the ovaries, but then also she is at higher risk for ovarian CA in some cases. So then we have to follow with the ultrasound monitoring for the ovaries. But if it is an early stage endometrial cancer, there can be a micrometastasis to the ovaries. In those cases, ovaries has to be removed. This also should be actually discussed with the patient. If she is like around 50, we can consider removing the ovaries, considering the fact that post-operative sometimes it comes as microinvasion in some of the in some pathology reports, and then we have to consider removing the ovaries and all that. So in these cases should be properly discussed with the patient before taking a decision. So in this patient, because she's 42, we can consider we can preserve the ovaries, considering the fact that it is only atypia. Not
Sheila madam, anything you want to add up regarding the first case, madam?
The first case was without atypia. So,
yes.
Taking the risk factors into consideration, which everybody has mentioned, okay, and the patient compliance, we should be sure that she is willing to come for follow-up. If we have started LNG IUS 6 months later, a repeat biopsy to see whether it is reverted back, okay. Otherwise, we may have to take a call. If it comes as normal, then we can repeat every year for 2 consecutive years. Okay. And then if it is negative, then yes, we can assure her that LNG IUS is helping her. Okay. That should be there along with lifestyle modification. Because if her BMI is more, that will again contribute to endometrial hyperplasia. So diabetes, hypertension, any other risk factor to be taken into consideration.
Yeah. Thank you, ma'am. Thank you. So I think we have completely covered the endometrial hyperplasia, both the concept with atypia, without atypia. And I hope that it's a very clear case of endometrial hyperplasia. So now we move
Can I add one thing? With
yes, ma'am. Yes, ma'am.
the follow-up is much more frequent. Like, I mean, you do biopsies every 3 months.
3 months.
Till you find regression, and then you continue to do till 2 negative biopsies you get. So that is the follow-up is much more frequent for atypia.
Sure. Yes, ma'am. Thank you,
But
ma'am.
atypia, I think, except that the patient wants, I mean, if it is fertility intervention.
Yes,
it's better
Otherwise,
to go for surgery.
And there is a new thing coming up, that is IETA, like how we have aorta for endometrial hyperplasia. But I think we will need more studies where they try to, it's a simple scoring methods, okay, where it can help us to differentiate between benign and malignant. Okay, IETA, International Endometrial Tumor Analysis, which is a simple scoring. Biomarkers are there for endometrial cancer and carcinoma, and endometrial lesion and uterine cavity lesions are taken into consideration. So in future, we can look at that even with, that is the ultrasound like aorta for ovarian masses, the same.
Yeah, it is very much operator dependent because, measuring the endometrial thickness or looking for a tumor, all that is possible, but it needs some expertise.
Yes, ma'am. Thank you. Thank you, ma'am. Thank you, Sheila, ma'am, for this nice depiction. And one more thing that I want to tell you, because you are logging into two instruments, ma'am, your voice is echoing. Probably you can disconnect from one, either from one mode you can have, ma'am, because there's an echo in your voice. So now moving on to the next
thing. I will just come out of that.
One thing, the echoing is there, ma'am. So it's not. It will be very
I
clear
did
if
it.
you log in with one instrument. Yeah.
I will do that.
Yeah. Thank you, ma'am. So next case, we are going on to another women, 45-year-old women with menorrhagia, dysmenorrhea since last 1.5 years. She's a multigravida with 2 children. Last childbirth is 17 years, and she has on ultrasound. Her uterus is very bulky with a normal adnexa. With endometrial thickness is very normal. No other obvious pathology. The pelvic transvaginal ultrasound scan, and her hormonal pattern, the thyroid is very normal, and she's very much worried about the heavy menstrual bleeding, and she has many doctors she has gone in, and there is still she's suffering from that. May I ask Dr. Suma Vishnu, madam, to say about how you will approach this case?
Yes, madam.
What is the diagnosis of this patient? Yeah.
Yeah, I think this is one of the commonest case scenarios we encounter in our day-to-day practice, because the thing is that she is suffering from the symptoms, but it's very difficult for us to find the etiology. And first thing is to rule out all the structural causes, and we have done that. And the second thing is to evaluate her hormones. And since there is no structural reasons for the abnormal uterine bleeding, she comes to the category of AUB of non-structural causes in the palm coin classification. On the non-structural causes. So with regard to the treatment or evaluation of the AUB of non-structural causes, first we have to have to see whether she is having any hormonal imbalances, and thyroid is first of all ruled out. That is one of the most common cause. And the second most common cause is coagulopathies. She can have any blood dyscrasias depending on the place where she is coming from. So all these things we have to rule out. And if everything is okay and still she is bleeding, we have to start her on with the treatment. Like the treatment can be pharmacological treatment and definitely surgical treatment. We can categorize that. And if I move on to the treatment part, the treatment of can I continue, ma'am?
Yeah. So one more thing
Yeah.
that you want to highlight here is the iatrogenic. Sometimes they will be on blood thinners, the aspirin, your
Yes.
clopidogrel, all these things
Yes,
can
ma'am.
have a bleeding. So we have to
Yes.
insist on them. Vitamin C
Yeah.
deficiencies, all these things has to be highlighted. We have to check
Yeah.
a proper history, which is very important when we look into the patient. That's what we really have to look into the patient, because many a times they come even with a postmenopausal bleeding who may be on asprin and with nothing
Yeah,
in their
definitely, ma'am.
endometrium. So we have
Yes.
to think of all the antihypertensive. Everything has to be detailed history, or has to be done in this case of a non-structural AUB, which is very
Yes.
important.
Ma'am,
Yes, ma'am.
iatrogenic, again, I think sometimes they'll not tell you that they have some autoimmune pathologies. They're already on some steroids also. So
Yeah.
you have to take a very, very detailed history.
Okay.
Even
Okay.
methotrexate for arthritis and so many other causes,
Yes,
they are
yes.
on methotrexate.
Yes.
So
Yes,
can I ask Dr. Radhika Gauri to talk on the treatment of AUB with a non-structural cause? Now we know that this woman has a non-structural cause of an AUB. Dr. Radhika, can you explain how you are going to treat her? The broad outline of the treatment for this woman. Are you there?
Affecting the quality
Or
of
else,
life.
madam, if Radhika is, yeah, she's there.
Yes, sir.
Thank you, ma'am. Since it's affecting her quality of life badly, I would suggest her to start with the medical management. The first is tranexamic acid, and I will suggest her to take 1 gram, 500 milligram 1 gram TDS 3 times daily for a period of 3 days. from the start of her bleeding, and I'll ask her to make the chart of her bleeding, how it reduces, and I'll review her entry after 3 months.
We can't hear at all.
Yeah. Your audio is still not proper, madam. We could not hear it properly.
Sorry, ma'am. Can you hear me now?
No, still it's not very continuously. It's breaking. Your
Okay.
voice ups and downs. Probably your audio system. You have to check.
Can you hear me?
Madam Suma, madam, can you highlight, madam? Can you correct your
Yes, ma'am.
audio,
Yes,
madam
yes,
Suma,
ma'am.
madam? If you can get into it, please.
I log into the mobile.
Yeah. Dr. Suma Vishnu, madam, can you
Yes, madam.
talk on this treatment part, pharmacological part,
Yeah,
how you?
definitely. Yeah, the treatment part of non-structural AUB, we can actually treat them with non-hormonal agents, which is actually very common. But the evaluation should be complete and make sure that she's not having any big blood dyscrasias. Everything should be.
Your voice is also breaking, ma'am. Network is, I think, slow.
Hyaluronic acid, definitely. And this, can you hear me?
No, it's breaking, ma'am. I think Padma, ma'am. So, madam, Dr. Padma, madam, can your network is strong?
I think so, hopefully.
Please, ma'am, please. So you can highlight on the non-hormonal and the hormonal, yeah.
Yeah, there is a non-hormonal and a hormonal treatment are available for this. Non-hormonal, mainly we start on non-steroidal anti-inflammatory drugs, and like mefenamic acid, it reduces around 25 to 50% of bleeding volume. The next we can use antifibrinolytics like tranexamic acid. It can also reduce up to 50% of bleeding. Then there are drugs like cormeloxifene, and then there are other treatment like hormonal treatment. Hormonal, we use progesterones routinely. An oral route is preferable. And for the first initial phase, I use oral route, and then after 2-3 months, when the bleeding gets controlled, I will advise an LNG IUD releasing levonorgestrel.
So as you rightly pointed out, Dr. Padma, madam, this is actually, we should start with the non-steroidal anti-inflammatory drugs, which can give a 50 to 60% relief of the pain and the dysmenorrhea as well as the bleeding. And then we can even give some fibrinolytic agents, which can definitely make the flow very much lessen, because many a times the fibrinolytic effect on the endometrium, which will be the main cause for the menorrhagia. And along with it, you can give ormeloxifene, which is also a very standard safe drug, which can be given to prevent the bleeding in a better way. Sheila, ma'am, you want to add up anything?
Yeah. Now, when we talk about antifibrinolytic, that is tranexamic acid, we have to give a proper dose. See, even we can go up to 3,000, but what we are giving is very less, and then it won't be effective. Now, suppose even if we have a tranexamic acid with mefenamic acid, we are combining, so we give that 500 milligram and mefenamic 500 TID. But if you are giving only tranexamic acid, you can go up to even 2,500 to 3,000 milligram. So the dose has to be adjusted that way. That is one thing. And coming to another, that is ormeloxifene, if we are using, okay, the patient needs follow-up. One thing is it can form a persistent cyst in the ovary, and 7% patient can develop endometrial hypoplasia. So if we are giving it for a longer duration, anyway, the recommendation is not more than 6 months. Okay. And we have to assess for endometrial hypoplasia. Only 7% can develop, but we will have to look into it.
Yes, ma'am. So that's a very important one. We should be very careful when you're using ormeloxifene, though it is a very important drug which comes in the armamentarium. But still, we have to be very careful when we are using all these drugs. The safest will be our mefenamic acid and our tranexamic acid, which are the mainstay of non-hormonal treatment for this non-structural AUV.
And one more thing, if the patient is anemic, in her, the clot will lyse early. So all the more in anemic patient, there is a role of tranexamic acid. How we say in postpartum hemorrhage now, woman 2 trial,
Yes,
that that clot dissolves early. So here most of the AUB patients are anemic, okay, and the bleeding will not get controlled, so we can give them. Theoretical risk of VT is very low, so we don't have to worry about it, except the patient is a real high risk.
Sheila ma'am, can I ask you what is your experience of ethamsalate along with tranexamic acid? Do you have the experience?
No, sorry. I mean, I used to use it earlier, but now we know that ethamsalate is not effective. Sometimes I do prefer to use in adolescents. Okay. In adolescents, I use ethamsalate combination. I find it more effective there. But here it is with mefenamic acid.
Yes. Thank you, ma'am.
Okay, thank you, ma'am. So, Madam, Dr. Padma, can you just still more elaborate? You were talking on progestogens. You told about the oral route, injectable route. Can you little more elaborate on the dosages? And very important, that is how much you use as a regular, because many times the delegates wants a detailed one. Can you elaborate on the oral progestogens, how you use, whether you use a cyclical or a continuous? Can you elaborate on the regimens which are available for control of the AUB in non-structural?
Yes. If the patient is who is on tranexamic acid still is if the bleeding is not controlled, I will start using progestrogens for cycle regulation and to reduce the bleeding. Initially, I will start. I may give norethistyrone acetate 2.5 milligram to 5 milligram daily from 5th to 25th day, or for a 20 days period, and then assess her bleeding. And if the bleeding is well controlled, I will continue with the same for the next 3 to 6 months. If the bleeding is not controlled, I will start increasing the dose. Otherwise, I will start her on medroxyprogesterone acetate 2.5 milligram to 10 milligram daily from day 5 to day 25, or micronized progesterone 200 milligram to 400 milligram daily.
You have any experience of using the megestrol?
No.
So this is only used in a hyperplasia where there is a simple hyperplasia without atypia. We can use this megalase or the megestrol, which is indicated in the women who want to conserve the uterus when they have a hyperplasia, especially in the PCOS women who has a hyperplasia. This is the very important drug of choice, which can prevent even a simple hyperplasia with atypia, which can revert to a simple hyperplasia, or even it can revert to normal. So this is a very important drug of choice, the megestrol, which is very much important in the simple hyperplasia in the use. Can I, Madam, just want to say a few words about the norethistyrone treatment with a micronization combination that has a very good control formulation, which has been in combination with the norethistyrone with, this can be used for the treatment purpose. So, as rightly talked by the panelists, oral progesterone therapy is the first line of treatment, which can be used as cyclical or a continuous till the flow gets arrested. And then you can even supplement that in the luteal phase so that you can prevent the hyperplasia happening by the progesterone support. So, we'll move on to the next treatment, that is the intrauterine hormone releasing system. When she's not
Organizer, please mute everybody.
Yeah. So, Madam Mavish, can you talk on this intrauterine hormone releasing system for AUB?
We're having a little disturbance in the background. Can
Dr. Mehananda has to mute?
Yes, ma'am. I'm muting everyone else.
Yes. So, can Mavish, can you talk on this intrauterine hormone releasing system for AUB? Madam is there?
Ma'am, although these oral pharmacological agents have a very good result, but there's a problem of acceptance because the patient has to take it for a prolonged period of time. So better option next, for a good acceptability, I would prefer that patient to go for LNG or IUS system. This releases approximately 20 microgram of levonorgestrel daily, and it results through bleeding is reduced by several mechanisms, and there is 71 to 96% reduction in bleeding volume and consequent improvement in quality of life. It has got better acceptance because the prolonged because it has got very less side effects. This LNG-IUS, it acts by preventing endometrial hyperplasia by reducing the endometrial thickness, and it is effective up to 5 years, although the contraceptive benefit is only for 3 years. And studies have shown that people who have opted for LNG-IUS, subsequent hysterectomies were not needed in the long run. But the only problem with this is that initial few months they'll be having a lot of irregular bleeding, but it can be taken care by adding on OC pills, and these problems usually settle within 3 to 6 months. Other problems like progesterone side effects can be there, like edema or weight gain. But studies says that LNG has got very excellent results in the long run, and it scores equally with the operative treatment also.
Yeah, so you're right. So there has been a lot of good news about LNG IUS, and also there are some initial discomforts with this in the form of bleeding, intermenstrual bleeding, rejection, and then expulsion. Sometimes the position, distorting the position. All these things are quite common, but still, this is a very, very standard and very comfortable, treatment of choice for AUB without any structural malformations. So I think this is a very important one. A Cochrane review says that the LNG-IUS is the more effective than cyclical norethistedone, and there is a very less, mean blood loss is very much reduced, and it is very effective, and it can really save the uterus, and can the women sustain for 3 to 4 years, so that her menopause will come, so that all the complications of this surgery, everything can be minimized by the LNG-IUS. There has been a lot of comparative studies with the LNG, with the minimal invasive, with the other modality of treatment. Definitely, it scores higher in the better treatment outcome with this LNG IUS. Madam, anything you want to add, Dr.
Shubha.
Shubha, madam, can you add on something more about the cycle? Because sometimes progesterone, we don't know how far we have to take along. Simple available drug. How about anything you can suggest on the hormonal treatment?
See, what I have seen is if the LNG IUS is not effective beyond, patient continues to bleed, what is most important is to rule out a endometrial polyp there. Because if there's a polyp and you have put the IUS, it may not effectively work, though it should actually. But a thick fleshy polyp sometimes will not respond to the LNG IUS there. So that is one thing I have found practically, that you must rule out a polyp, thick polyp inside. And it is otherwise a very, very convenient thing. Only problem is if the cavity is bigger, or if it is distorted by some small fibroids or intramural fibroid, then it becomes very difficult. So those are the patients who may need other modalities of treatment, like thermal balloon ablation, or some more definitive treatment may be needed. If it's a submucous fibroid, of course, you have to do a hysteroscopic resection.
Okay, so that completes our case of
regarding oral
Madam.
contraceptives, Dr. Jairani.
Yes, ma'am.
Sometimes we get the histopathology report as disordered. Okay. Yeah.
Yes, ma'am.
And we don't know mostly what to say. It is in between. So those patients will be benefited by oral contraceptives, because you have removed the unhealthy endometrium and the new endometrium starts developing. So we can put them on OC pills, and that can be given even for 6 months to 1 year. Okay. Sure. It is nothing but a proliferative endometrium.
Yes, ma'am. Yes, ma'am. So, Madam, Shobha, madam, can you say when you will advise the surgical treatment for AUB without a structural lesion? So we were medical treatment is, there are a lot of drugs which are there. Will you advise a surgery for her? Any of the occasion? When there is a surgery is indicated?
When they're not responding to medical management, and when there is no follow-up of the patient, like they're not ready for follow-up, and if the patient insists, if she is perimenopausal and if it is really bothering her.
Yes.
Can I add to that?
Yes, ma'am.
Yes,
The
please.
thing is, suppose a patient has come to you and she gives history of 3 transfusions 6 months back, and now she has come back again and she's anemic. And sometimes it happens, they lose so much blood, they take blood and they're again anemic. So these patients are not going to respond to your treatment or non-compliant. This is the case where I would, suggest a hysterectomy for her.
Yes.
Yes.
Nigarika?
Yeah. So we'll proceed with another case scenario. So she's a 46-year-old with heavy and painful periods for the last 2 years. Her cycles last for 5 to 6 days and she has 80 to 23-day cycle length. So presently her hemoglobin is 9, vitals are stable, 70 kg women. So you can see on TVS that the uterus is uniformly enlarged and the myometrium shows a mottled appearance suggestive of an adenomyosis. So how would you how would you proceed further? She has a very small cyst also, 1.8 to 2 centimeter cyst. Otherwise, everything else is normal. So can Dr. Shamima elaborate on the treatment of AUB in a structural causes? How do you proceed when you have a structural problem? Dr. Shamima?
Okay. In this case, the ultrasound, I mean, can we go to the case again, please, madam?
Yeah.
Yeah. So she's a 46-year-old with symptoms of heavy bleeding with pain, with anemia, and ultrasound is showing a more often adenomyosis meiotic appearance.
Correct.
So still, it may be AUB A, but still we have to, because she's 46-year-old, we have to do a pipple endometrial sampling in this case before going for any medical management. So to rule out any endometrial hyperplasia.
Absolutely.
After that, we can, if she's continuously bleeding, after that we can discuss, once we rule out the any malignancy or hyperplasia, then we can discuss with her depending on her symptoms. She's already anemic, so she needs a hormonal treatment, I feel. So we can give progestogens, like the new Dynogest is a very good option. After giving for 6 cycles or 3 to 6 cycles, if the bleeding is controlled, then we can switch on to LNG IUS. Immediately switching to LNG IUS, I have found that practically it is they don't succeed so much with the LNG IUS. Putting them on progestogens and then shifting to LNG IUS is better. So many people they respond to this treatment, adenomyosis. But adenomyosis, the pain, if the pain is persisting or if they are not responding to treatment, then only the surgical management comes. So if it is in this case, it's a diffuse adenomyosis. If it is a focal adenomyoma or something, then we can actually, if it is a focal adenomyoma, the differential diagnosis may be a fibroid also. So in that case, MRI may be helpful in differentiating the focal adenomyosis with the fibroid, and that will also help in the management. If she doesn't want to remove her uterus, or we can consider an adenomyomectomy or myomectomy, if whichever route is feasible depending upon the position of the myoma.
Suma madam, will you add up any medical treatment for this women? Suma Vishnu madam. Suma? Dr. Suma, you are there?
I think her network is bad.
Okay. Fine. All right. So
we can try GnRH agonist in this patient. Suppose GnRH can be tried in this patient if they're not willing to.
Yeah, they can with the add back therapy, because it will need prolonged treatment. She will need an add back therapy.
See, sometimes, can I come in? If you find
Yes,
that the
ma'am.
uterus is really big and it can expel the marina, in those cases, we can give GnRH and then insert the LNG IUS.
Yes.
Even that will also reduce the rate of expulsion. Yeah.
Yes.
So
Sometimes
now,
it's very difficult to put it also. If it's a very big uterus, you will not even be able to.
no,
So
we
I
can
think
put it, but expulsion rate will be
very
more,
high.
very high. And the another drug which is now still not available in India but available in all Gulf countries and Bangladesh is the new drug is Elagolix.
Yes,
which inhibits
antagonist.
the antagonist. Okay,
Antagonist.
and
Oral,
it's giving,
oral antagonist.
yeah, oral, and it gives very good results. You can start with a lower dose up to 100 mg BD. You can go even higher up also, and at it suppresses it acts on the receptors. You know, it's antagonist like action. So that also has a role in adenomyosis and giving a very good results. I think which can be given even for 6 months. Like if somebody is nearing menopause, you know, where you don't want to do the surgery, like how we used to say earlier, we can give GnRH agonist. So here we can use this drug also, except if there is any liver disorder, it's contraindicated. Otherwise, it's a very safe drug. If the patient is younger, you may have to advise her contraception also, because it may not suppress ovulation, and suppression of ovulation is dose dependent. With lesser dose, the patient can still sometimes can ovulate. Okay, so
Yes.
that is the another drug which is giving very good results.
Thank you, ma'am. Thank you.
Thank you so much for those insights, ma'am. So now,
in fact, practically, we have found Dynogest to be very, very effective.
Very useful.
Patients
Yeah,
are
yeah.
so happy that they don't have pain and they can use it for up to 6 months. And after that, as the previous speaker had said, I follow it up with the LNG intrauterine system. And of course, not for a very big uterus, but up to 12 week size. It works quite well. A small chance of expulsion, which is not very high. So instead of hysterectomy, she can definitely try it out.
Even
Madam,
letrozole.
and,
Even letrozole
Yes.
can be used. That also can be used for the adenomyosis along with all
Correct,
the drugs.
letrozole
That
also.
also has a very good
Some
effect.
Some
Madam, even
patients who are comfortable with the Dynogest, they are even continuing for more than 2 years with
Yes,
me on Dynogest. And some do get irregular bleeding. In such cases, it's very useful if you tell them to break for a period of 7 days and then restart.
yes.
Then it is very useful. Adding a estrogen containing OCP also is sometimes useful in certain cases, but sometimes we don't want to give estrogen, means this is very really effective.
Very
And
true.
Initially, when we start a Dynogest, it is always useful to start with the OCPL along that. That will prevent the intermenstrual bleeding. That is very common with the Dynogest. So to the complaints of the patient, acceptance, all will be very well appreciated if she starts along with the OCPL and then continue with the Dynogest. That is a very important side effects of Dynogest in the initial phase of the beginning of the treatment.
Madam, I've noticed one more side effect with Dynogest when used for a long time. Glucose intolerance is very commonly seen when used for a long time. So we always have to check for the sugars in these patients.
oh. And the problem is the patient has come with pregnancy also. So we have to tell them about contraception.
Yeah.
Yeah.
So, Niharika?
Yeah, especially perimenopause, you know, we are sometimes surprised with pregnancies, though the chances are little less. But we have to be very, very careful that, you know, we don't have pregnancy on our hands.
Yeah. So can I have Dr. Radhika take up this?
Yes, ma'am.
Can you elaborate?
Can you hear me?
Yeah, we can.
Okay, ma'am.
Tell us what Foxy tells us about the guidelines for adenomyosis. What are the GCPR guidelines?
So the Foxy guidelines are based on the etiology. Mainly, if it's a polyp, then it's best to do a hysteroscopic surgical removal. And if there are multiple polyps or polypoidal endometrium, and if there is no need of, if fertility is not an issue, then we can go with a LNG-IUS, and we can combine it with a surgical removal as well. So we can remove it and insert a polyp. And then the next is the adenomyosis. Again, adenomyosis also, we can try if the size of the uterus is normal, if cavity is not distorted, we can insert a LNG-IUS. And other option is the GnRH agonist with add-back therapy. And hysteroscopic polypectomy is effective and safe option, and rapid recovery is there. Adenomyosis, we have to make sure that symptoms can be controlled with the suppressive therapy. So we can either give the GnRH and then followed by the LNG IUS. And as we all discussed, we can give the combined contraceptive as and progesterone as well for adenomyosis.
Okay. Dr. Padma, so I think we've discussed most of these things previously also. So can somebody throw a light on HIFU, Dr. Padma? Dr.
Padma, are you
Padma?
there? She was there only.
Padma
Yeah.
ma'am has disconnected
Padma,
due to network issues.
yeah.
Actually, ma'am, can I? Actually,
Yeah,
we
you
have,
can proceed.
yeah, because when I
No, you have to unmute Dr. Radhika.
sorry for the
No.
interruption.
Ah,
We have
yeah.
used in
Keep
I
your
heard
mic close by to your. Yeah. No, we can't hear you. I'm sorry, some problem with your audio system.
sorry.
Now we can hear you. A little we can hear you. Yeah. No.
Okay.
Can somebody
Madam,
else take it up?
Madam Mavish, can you take it up or about
Yes,
the
ma'am.
HIFU, can you talk on that? Yeah.
Yes, ma'am. So HIFU, it basically uses high intense ultrasound energy, which is directed towards the abnormal tissue and the vascularity by heating and cavitation, and it spares the normal surrounding tissue. So this process can be guided and monitored through an MRI or an ultrasound, which is obviously high intensity, and it has been already being used since 2008 for the treatment of adenomyosis, but it requires a better setup, and literature is promising. It shows promising results regarding the symptom relief and uterine preservation with few reported complications. Second option is uterine artery embolization. in this uh, in this uterine artery embolization, what we do is we block the uterine artery similarly the way we use for fibroid treatment. It can be used for adenomyosis also. It has got excellent results, but still we are awaiting the results of the Questa trial to make it as a standard procedure. So it can be used if the results of Questa trial are, if we have the results, because it has got excellent result and it is the most investigated treatment, and it is also very minimally invasive treatment. So for
Yes, ma'am.
fibroids as well as for adenomyosis, for both, we can use this uterine artery embolization.
Yeah. So we can use
I
these
think
as alternatives.
HIFU, I would
Huh.
like to say that earlier when it came, it was it became popular, but because of the side effects and the burns. Now, recently in Figo, when I visited that stall in China, now they have come out with focused, where the surrounding tissue does not get those rays. So they have come out with some focused probes, which goes, only applied to the tissue, where the side effects for the other tissues, the burns used to happen and it went out of practice. So maybe it might come in future to India also. But now there is the better version of that, which we'll see if it comes.
Right.
So Nikarika, you can take up. Yeah.
Yeah. So this is again a last case that we're going to discuss. This is a 39-year-old with 2 previous C-sections, 2 living children, and complaints of menorrhagia and dysmenorrhea. Her last menstrual period was 34 days before. So she also underwent a surgery for incisional hernia. So she's pale and the uterus is 14 to 16 weeks gestational size. So ultrasound shows multiple fibroids. So may I ask Dr. Shubha Ramarao, what would be the differentials in this case?
The one is she's amenorrheic, 34 days. And I
Yes.
don't know whether she's tubectomized. She's 2 previous cesarean. So I
Yes.
would like to first rule out a pregnancy, see whether she is pregnant.
Yes.
And then, of course, the scanning is showing multiple fibroids. And if pregnancy has been ruled out, then that's one diagnosis. But then apparently the uterus may look bigger because most of the time with 2 previous sections, what I have seen is the uterus is somehow pulled up or, is stuck somewhere and apparently appears bigger than what actually it is. So
Yes.
objective measurement on ultrasound is very important. so that, we are able to consider other treatments, because if it's a big uterus with multiple fibroids, other conservative treatments become a little difficult. So,
Yes.
so in
Ma'am,
this case, see, she's having menorrhagia and dysmenorrhea, and she's also pale. So obviously she's bleeding heavily. So I would really map the fibroids and see what is the location of the fibroids. If there are any submucous fibroids, treating them will relieve her of her problems. But if they are intramural, a subserous, of course, may not be responsible directly for her menorrhagia and pain, but it is the intramural and the submucous fibroids which will be responsible for her symptoms. So I would like to do some mapping if I have to treat her conservatively. Otherwise, even if I have to, if it's a submucous myoma, hysteroscopic removal of that fibroid will be a cure for her problem. So many a times dysmenorrhea with fibroids associated with submucous fibroids, depending on how much of it is in the cavity. And therefore, it is very important to map the fibroids and see what is the location, what is the size.
And there can be some concomitant adenomyosis also, which could be
Definitely,
causing
yes.
dysmenorrhea.
Yes.
So I think having a very detailed scan is very, very important.
Yes.
Yes.
And even if she is a Paris lady, doesn't rule out endometriosis also, along with fibroids, adenomyosis, endometriosis, all can coexist.
Yes. Yes. So
Even
do we have
periodic and even pelvic infection is very common with fibroids causing dysmenorrhea.
Okay. So, Dr. Shobha, can you elaborate on the FOXY GCPR guidelines for fibroids? So, how do we proceed? I think Madam has discussed some of it.
Yeah. If the fibroids are intramural or subserosal, tranexamic acid or COCs can be prescribed, or even NSAIDs can also be prescribed. If these treatment fails, LNG-IUS can be prescribed. If that also doesn't work, myomectomy is advised. So, woman is more than 40 years of age and fertility is not desired. For small fibroids, medical management can be tried, and if it doesn't respond, hysterectomy can be offered to these patients. For short-term management, we can also try GnRH agonist with add-back therapy, followed by myomectomy. By using GnRH, we can make large fibroids smaller, so that converting abdominal hysterectomy to laparoscopic or vaginal hysterectomy. We can
Also,
even try
mifepristone,
newer options like ulipristal, mifepristone can also be tried in
mifepristone.
these patients. Yeah.
What is the experience with ulipristal? Can somebody elaborate on it? For the delegates, what precautions should we be taking?
Liver enzyme should be tested before starting ulipristal. It causes liver damage.
Okay. What about mifepristone?
I think you have to give it for 3 months and then 1 month gap. Again for 3 months and then 1 month gap. And meanwhile, after every regime, you will have to assess her liver function.
Yes, ma'am.
So, yeah, that way.
But it is ulipristal is a very useful drug, especially in the younger girls,
Yes.
not even married. And I've seen fibroids of 20 weeks and 26-week uterine size, where because they are not married but having symptoms, pain and heavy bleeding, I have used ulipristal for them so that, temporarily they are better. And of course, they have come back after marriage. And then we have done myomectomy for them because they were really too big.
That's good, ma'am. Yeah, that is a very important one, that we should think of all the age criteria also when we manage fibroids. Dr. Shobha,
And
can you think?
post-operatively, Shubha, even sometimes post-operatively, it does recur, and we find that there is a recurrence, and we have done the myomectomy. Even for those patients also, we can put them on.
Yes.
Yes.
So, Dr. Shobha, can you tell about uterine artery embolization for this multiple fibroids to regress before you put for a surgery? Anything you just have an added advantage of UA embolization? Can you have any?
Yes, Whenever this facility is available, wherever we have an interventional radiologist, we can definitely try this mode because it preserves the uterus. Because our first preference is always to preserve the uterus. If the procedure is done in a proper way, it can be really useful, very effective. Under local anesthesia, it is done as a daycare procedure. So this can also be tried in patients who really wish to preserve their uterus. In a
But
center,
only if they have completed their family, not to be done for infertile women. Yeah.
Correct, madam. Only if they've completed their family.
Selection of cases is very important in uterine artery embolization because, and we have to counsel the patient regarding the pain. Sometimes the submucous fibroids can get expelled, and it's very difficult situation when the fibroid is prolapsing, necrotic fibroid is prolapsing.
Yes, very true.
The bleeding.
Yeah, sometimes they come with foul-smelling discharge, copious discharge, because it undergoes necrosis and it becomes, the patient really finds it difficult. You will wonder really from where this discharge is coming.
Yes. And then interventional radiologist and gynecologist should have a very good rapport. They should communicate to each other very well. That is, ruling out endometrial pathology is also very important before taking up for uterine fibroid embolization. Even though all these things matter a lot.
Yeah, so I think before doing any of these conservative methods, we have to be sure that we are ruling out malignancy and all hyperplasias. So that is a definite given. There is no compromise
Selection
there.
of cases is very important for any procedure or any method of treatment.
True.
Yeah. So I think we have done enough, and the Public Awareness Committee people will be throwing us because we have exceeded so much of time in the discussion of so interesting cases.
Madam, only one question I would like to ask. If anyone has experience of using mifepristone in uterine fibroids.
Yes.
Yes, definitely.
Yes,
and
definitely.
very useful in perimenopausal age group. They go to
Especially when you have a small submucous fibroid, when you plan for a transfer, I have done for one patient. It has beautifully regressed, and I've given her a pregnancy also because we can't put in and it's not
LNG.
inside the cavity as well as it's not into the intramural coming subendometrial. So that has gone a very good relief by that mifepristone I gave her. For 3 months I gave her, she was completely that size shrunk, and then I transferred.
Okay.
So I think we have done enough. I thank all the panelists. A very special thanks to Sheila ma'am and my
Thank you.
co-moderator,
Thank you.
Dr. Nigarika, for this wonderful, combined work that we have done. And to conclude that we have to, when you come across any women with an AUB in the perimenopausal age group, think of the palm coin, and we have to definitely group her in which group she belongs to and associate comorbidities and what is the condition of her position at that stage. And we have to do a very systematic workup of complete history, clinical examination. Very importantly, always rule out pregnancy. And the very important modalities that you have to look into it is a transvaginal ultrasound, a biopsy, as well as a very important hysteroscopic gadgets needed as per the case wise. And you have to plan a proper, correct process and procedure before you plan everything for her, taking into consideration of all the aspects of the women's life. And very important, you have to consider her family, her partner, and also her future partnership relationship also when you plan the treatment for the AUE. Because sometimes they may bleed for 6 months to 1 year and they never have a sexual life, and that will have a lot of marital relationship problem too. So every aspect of the women's life has to be considered when you manage a woman with a perimenopausal AUB. And I hope that, and I'm sure that all the delegates will be very much benefited by the wonderful discussion of each case scenario by my expert panelists and with madam's expert opinions and other things. I thank one and all for this wonderful presentation, and we all take the message of a save the uterus. We keep the surgery as the very, very last way. We have a lot of drugs, a lot of treatment modalities to save the uterus, and the surgical, hysterectomy should be the last in any of these things. So with this word, I thank one and all for the patient listening.
Thank you.
Thank you very much.
Thank you.
I thank all the panelists. I think everybody gave us so much more inputs than we expected. And I think Dr. Sheila Mane madam had such expert opinion, such new insights. Thank you so much, ma'am. We also learned a lot.
Thank you, ma'am.
Thank
Yeah,
you.
thank you, thank you, thank you so much.
Thank you,
Thank-
Jayanti. Thank you.
Thank you, Monica. Thank you, Monica, for this special invite. And thank you, all the senior faculties here. And thank you so much.
Thank you, Giovanni ma'am. Thank you, Niharika ma'am and Sheila ma'am for being an expert. I thank all the esteemed panelists for their excellent inputs, and I would now invite Dr. Monica Gupta madam to please officially propose the vote of thanks for this webinar.
From the bottom of my heart, I thank Rishikesh Pai sir, Madhuri Patel madam, Alka Pandey madam, and Kalyan Barmade sir for their continuous support to us. A special thanks to the PSC committee chairperson Priyankur Roy and the guest of honor Dr. Revati madam and the Patsy Lewis sir. My special thanks to both the speakers, Dr. Ambuja and Dr. Bharti Rajshekharan, and our chairpersons, Dr. Rajshri Palti madam, Dr. Raghvendra Prasad sir, Dr. Sonia madam, and Dr. Suchitra Sudhir madam. And special thanks to our panel team, which has done a wonderful job. Both the moderators and the experts and all the panelists. I thank everyone, and especially the Corona Remedy to give us the platform. Thank you, everyone.
Thank you. Bye-bye.
Thank you.
Thank you.
Good night,
Have a
everybody.
great
Thank you,
weekend. Have a
Abhishek,
great
for
weekend.
Thank you, Shubha ma'am.
Thank you, madam. Thank you, Shubha madam. Thank you, Monica madam.
Thank
Thank
you,
you, Radhika.
Monica.
Thank you, Shubha.
Thank you, ma'am.
Thank you,
Thank
Sonia
you,
madam.
Radhika
Thank
ma'am.
you, Monica.
Ma'am,
Bye.
Abhishek,
Bye,
special
Niharika.
thanks to you.
Sonia ma'am, thank you so much. Abhishek, thank you for the technical support.
Thank you, ma'am.
Yeah, thank you, Abhishek.
Thank you, Abhijay. Thank you.
Thank you. Thank you, Jairani ma'am. That
Yeah,
was
thank you,
great
Nirga. So
collaboration
it's
with
lovely.
you.
We had lovely thing together. You're coming to
Yeah.
Mumbai?
No, ma'am. I'll see you in AICOG.
We'll see then.
Yes.